You'll see this is a large board meeting. This is, just to be clear to members of the public, this is a board meeting in public, not a public meeting. So there's some questions from the public earlier, but it's not a discussion meeting. So very lovely to see you all. Apologies for absence. Damien in Doncaster, I think he's busy at the moment. Declaration of interest, anything new to declare from the standard declarations? Okay, thank you for that. Minutes of the last meeting on the March, isn't it? I understand you had an amendment, David. Where are you?
Yeah, just a minor one, please. So page 3 in relation to the virtual ward evaluation.
Yeah. And
it says wasn't expected until the beginning of 2025, 26. It should just say 2026.
Okay.
And that Claire's got the amendment, and it's in the action log as well, but we'll correct that. Thank you.
Thank you. Everyone okay with that? Anything else? Anything on the action log? Brilliant. We then have our storytelling. We always try and get a story about some patient experience or something, and we do that generally at the start of our meeting. And today it's about the Roma community. Katie, you're going to do the introduction. Brilliant. Welcome, ladies. Nice to see you.
Okay, so for the board story this time, we've got colleagues from Clifton Learning Partnership joining us, and we have got a video of a patient story, which we're hoping will be loud enough this time. I have had some comment support this time. So the patient didn't want filming herself, but you can hear her and you can see Martina translating.
Okay,
hopefully. They'll tell you a bit about Clifton Learning Partnership, but just a bit of background how we came to this being the story today. As part of the Start With People strategy refresh, we did offer people and organisations the opportunity to invite us to your meeting. Clifton Learning Partnership took us up immediately, and Shahida and Leslie went to visit them. And I think it's fair to say we've all been struck by their passion and the support they provide for an incredibly marginalised community, the Roma community. So we've asked them to come and talk about that area of work. So just a couple of things I'd encourage you to think about when you listen to Monica's story, touch wood it works. So knowing the context that these ladies are going to take you through of the community that Monica comes from, which has faced decades of persecution, I think you need to think about how important it is that she feels listened to by her health and care providers. That links to cultural competencies of health and care staff, which is something in involvement we hear about time and time again. It comes up almost as often as interpretation and transport and parking. Obviously, unconscious bias and whether that affects the care that somebody receives, and also assumptions of knowledge. So you'll hear, we all know that waiting times for hospital appointments are quite long because we consume that in the media. For communities who don't consume that, they feel like that's something that's just happening to them and not happening to the rest of us as well. And then obviously how this links to widening health inequalities. Monica clearly kept going, even though she felt unheard. I feel like many people from our underserved community don't. So without further ado, I will pass over.
Thank you very much for inviting us today. We really appreciate the time. I know this is very precious, so thank you once again. So I'm Helen Wood. I'm the CEO of Clifton Learning Partnership. And this is my colleague, Martina Sipakova, who works in various roles within the organisation. Martina's been with us for 10 years now, one of our oldest serving members of staff. And Martina has a wealth of experience, not only lived experience and the same language skills, obviously, still developed working with us. So we're a charity. We're based in Eastwood, in Rotherham, and we're there to support the community as a whole. But the majority of people who walk through our door are Roma people with local needs. And what we try to do is to build trust and engagement in order to be able to deliver services that people need. And I guess the way that we do that is by employing local people with the same lived experience and the same language skills. And that enables us to get trust and engagement, and then we can deliver those services that people need. I won't go into everything that we do. We do a heck of a lot, and we have a really strong influence. It's saying this because I'm really proud of what we do. But we're a very small team. We're 6.5 full-time equivalent, and I think the work that we do is probably equivalent of about 50 people. So we're really, really proud of what we do, but we know that we need to get stronger and stronger in order to represent and support the community to have a voice. So we're absolutely delighted to be here. We are not going to go through all the slides because we just don't have the time. So we're going to pick out bits, and then we'll show the video at the end if that works, and then take some questions. So Martina's going to start with some of the contemporary challenges with their own community face.
Thanks again. So we just go through challenges. So 2010 in France, 61 Romani camps raised. 1,230 not French Roma expelled. In many countries, Roma remain and experience with the barriers to employment, education, and health. High employment rate, low life expectancies, poor health status, low political participation, ghetto condition with no running water, children play.
So a lot of that's in Europe.
In
isn't it?
Yeah.
So in 2021 in England, with that census, so this number will come up as identified as Roma, likely to be underreporting. We, like CLP, I would not try to encourage Roma to put that box that we are Roma ethnicity. It's very hard for some Roma to present themselves that they are Roma because of history and the young community with 75% under. Roma communities continue to have worse outcomes, low number of Roma children for preschool settings, 54% of young Roma left school early, poor health condition, high unemployment, often linked with connection and lack of skills and education. So we can go to slide 9. The main challenge is communication. So interpreter is big one. Explain. It's very hard because when you go like interpreter, you explain who you are, and when people say yes, 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 they coming back to us, and when I ask them questions, who you can see, and they're like, I don't know. So sometimes it's that like even if they're Slovak language, not everyone understands when you have no vision and family structure. Roma family is a big family, so we know that family go 7, 8 kids. Like really quick example, when grandparents come to house, so they will not send them to hotel, even they'll have the food. They will sleep all together and try to support each other. And for some professionals, it not look okay. And then when miscommunication go in there, so it's more traditions and how we live. Fear and distrust of authority. So bad reputation of how they treat and remove children. Roma families find it hard to trust social workers against the communication between social workers and Roma families. Help build good a relationship to be good outcome for both parties. Possibly more. Lack of knowledge about UK services. So it's still long process so people understand the system here and law. It's how you spend and how you explain. It's very hard. We're talking about NHS, how the system works, you can wait for all equipment, and sometimes, not sometimes, quite often not being heard. In Slovakia, it's different. So you book appointment, but not in like, let's say in NME, You just go there, waiting, I can say 20 minutes, and you're not going to nurse, and then from nurse to another person, and so it's going straightforward. Max, you can wait 1 hour, not more. You don't need to book appointments. You don't need to wait for scan, 8-7 months. You just go to another different department, and they'll take you straight away. Because sometimes, quite often, people going back to my country because they cannot wait longer here. Stressing, they don't know what's going on. So they rather than going there and pay because they don't have insurance. So they will pay for treatment, but they know the outcome straight away. Then we have poverty and issues. Poverty is always going to be challenge for professionals because you can work with families, see regularly, but you still don't know what they need. So how you can support them with clothes, food, or activity for kids. Our main problem is housing, about landlords and limited resources and time. Back to communication and build the trust. Professionals to be able to invest that time with families, that it's going to be easier to break down the trust.
Thank you.
Okay, so we're going to skip a slide and then go on to Roma and health, slide 14. So as Martina said, there are many issues that health professionals come up again. We'll be trying to break down some of those barriers that are preventing people from getting the support that they need. So as Martina's noted, and I'm sure you're aware, that life expectancy is lower because of so many issues such as poverty that Martina talked about. They generally don't prioritise their health because they're living so much day to day, and the priority is to get food on the table, to get to work, get money. So health is very often not prioritised. So it can come across that people aren't interested and don't care, but they actually do. But sometimes they will leave it till the last minute to get that health provision when they are desperate, I guess. So there's little sort of concept of prevention, is there, in terms of looking after your health, in terms of leading a healthy lifestyle. Those sort of things are not conceptually understood. And as Martina alluded to, when we try to explain to people, it takes a lot of time. So as Martina said, people often come and go, yes, I understand, when they actually have no clue. Partly just to get rid of you because they don't want to spend more time engaged when they really don't understand that they want to wear. So what Martina and other colleagues will do is spend a long time unpacking those concepts for people. There often isn't a direct translation of the word. For example, when we did some work around sexual exploitation, there is no direct translation. So it is, we have to unpack it and explain it, and then obviously maybe do that again. It's not just the language, it's the concept. Well, that's difficult. People have lack of skills, so again, opportunities, their job opportunities are very limited. But again, that pressure to just exist. People are living at the moment, a majority of Roma people, I would say, that we support are living hand to mouth, and it's about survival at the moment. There are some areas in the country where the Roma people are doing better than that, but I would say certainly not in Roma. And many of the Roma people we support are Slovakian Roma, aren't they? And they've been some of the most discriminated again. There are Hungarian Roma, there are Romanian Roma, there are Spanish Roma, and the commonality is that they might speak a similar language, although they're different dialects. But the Slovakian Roma have faced more discrimination, as Martin said, segregated schools, being forced to live in ghettos where there's no running water, no electricity, etc. So those people come to the UK for a better life, for a better life for their children. Sometimes as adults they don't prioritise their own health. They're here because of their children, and they want their children to have that better life. Is that fair? Just jump in. Okay. As again, Martin has alluded to, those previous experiences impact on Roma people and how they engage. So again, I know you'll be aware that really modern times, I think it was 90, recently as 96, there was forced sterilisation of Roma women under the communist regime. And that's really recent history. It's in the common memory. So although they might not have directly experienced that themselves, it's the family history. It's embedded through to the younger generation. So there's that severe mistrust of what are they going to do to me? And if you don't understand the language, you don't understand the concept, it's backed up, doesn't it? So we have an example of one of our workers, doesn't work for us anymore. Her daughter had some health condition. And when they were doing the HPV vaccine, is that the right one?
Yeah.
She said she didn't want her daughter to have that done at school. She wanted to check with a specialist that it was okay. But the school ignored her and gave that child that vaccine. And we know that, okay, the child was fine, but actually it went against the mother's wishes, and it happened, a few years ago. Those sort of things that, well, she doesn't understand, and I'm making assumptions here, but I'm assuming that's the thought process. She doesn't understand it's the right thing for this child to do it. That's my assumption. But that leads to that story being told, and then it's told to somebody else, and then that leads to, that area of trust. And as Martina said about social services, mistrust there is huge. And I do feel that if we don't sort that, you will be working, not in a vacuum, but your challenges will be more difficult, because even if they begin to health services, that massive fear of children's services and children being taken into care. And I think that's something that we have to address sort of nationally. And quite frankly, we're struggling to do that. We're fabulous that you're engaging with us. We're so pleased. But for us to get in a room around children's services, we would struggle, I think, to do that. And that's one of the key that I think we need to think about. We've talked about the knowledge of the system. We haven't mentioned digital exclusion. I think that's a given. The language barriers, we've talked about those, that no direct translation, little information. Health isn't commonly discussed, especially personal issues, women's health, mental health. Women's issues will be talked with other women and not necessarily with male partners, etc. So it's quite compartmentalised, and women will trust their mothers, their grandmothers, etc., and what they did, and use that sort of community knowledge rather than looking for external information to support them. I think we move on. If we can go on to slide, where are we? 15 for the next slide. So what works? So we know we don't have all the answers, and please don't think that we think we do. They're massively important relationship, and how we work is, as I mentioned, with lived experience, with language skills, and we work from the bottom up. We work with people, listen to what they want, and we work from there. And we believe, and I think the evidence is that if we work from where they are, then we can engage with other things as well. So one of the primary needs is advice and support, isn't it? So we do a lot of advice and support, from translating a letter, making a GP appointment, any of those things, through immigration. It's wide as that. But because that's what people want, then they begin to trust us because we've done that. And then we can say, what about some English language class? What about some IT class? We could they'll come in and use one of the companies. So we use that as a vehicle, working absolutely where the people are at and what they need. And then it gives us that permission to be able to have more difficult conversations with people further down the line. It takes time and resources to change views and build trust, challenge previous experience. And I think that's sometimes not understood, that we can't, it's not a quick thing. Sometimes we'll put people together in a group, but actually sometimes Martina needs to just talk one-to-one to somebody. In a group, it won't work. And it just makes it more difficult. Doesn't mean we don't do it. It makes it more difficult to kind of get that. Has to be done in the right way at the right time. Because we could forever put messages out on Facebook about health, about when to put the bin out, anything about going to school regularly, but it's got to be relevant to people at that point in time to help them to engage with it. And then we get that right to have the conversation. And as we know, it's time to build knowledge, trust and health literacy. So, quick example is we did a Healthy Family Fun Day, and it was through Family Hub. And again, it was about the community's agenda, not NHS driven, and focused on fun activities with a dental link health information. So we invited lots of people to come. Do you want to go on to the next slide, please? I'm not going to go through all this, but we had a really good attendance. Everybody who came, like the midwife, 19 team, perinatal mental health. Forgive me if I get the words wrong. And they all provided a fun activity, but then offered something else, smoking cessation, for example. People went up and had a conversation and played the game, and then that led to other conversations. So it was a really well attended, and we debriefed afterwards with professionals. Community enjoyed it. It helped break down barriers and raise awareness of various health issues, including sexual health and dental health. Let's go to the next slide. So in terms of the evaluation, we came up with these, that we need to move to science, physically and metaphorically, in terms of legislation and understanding. Some existing practice doesn't lend itself to making every contact count. We came across midwives not knowing exactly what the 19 team was saying, and they vice versa. So it wasn't quite marrying up some of the information. So some services weren't aware of key messages from other services. And the other example was that I think when midwives went to family homes, they worked with the pregnant woman to talk about smoking cessation. Everybody else can have smoking. They didn't have those conversations. That's the protocol. That compassionate and respectful approach, coming from no hierarchy, increased social interaction, building the trust, partnership working. We've got trust and engagement. Work with us. We've got the language skills. Work with us. We can't do it. We don't want to do it all. We just want to make things better for people. And one of the big things was it was noted that if we're willing to adapt, learn, and work from where clients are at in the Roman community, they're not hard to read. And that was actually what the professional said. It's not really a difficult thing to do. We accept, takes time, takes money, takes energy, but in reality, through a very simple fun day, we began to break down some of those barriers. Okay. And the last one, am I all right? No. We find it this time. So I'll quickly go through those. Some of the things that we think would be useful to consider: connections, work with trusted organisations, employ Roma people. That's for hours, won't. But we can talk about that if you want. Individualised care, recognising those differences that Roma people come with, and take the originally said, understand culture, develop cultural competency. And then we work with them. I'll pick up. Thank you.
It's 4 minutes. Would you prefer us to send it round?
I think it might be better if we sent the video round and we allowed people to think about it, reflect on it, ask discussions. Are you okay with that? But we will send the video round because I think there might be points arising out of it. I'd rather have that than the video. Is that okay? Right. Any points people want to raise? Greg.
Great. The history lesson really powerful at the start of the second point, the hate vaccination example isn't okay. Yeah, figuring that fundamentally undermines informed consent. And I mean, the word historical, but hey, why do folk not trust services? I think we should reflect on that equally. My question, sort of resourcing and how sticky is it? And what do my quiz? What do your funders say about what good will come, what you say about what good? And then those two things match. Sorry, I can't put you on. No, that's I'm the problem like direct.
Yeah, we've got a lot of work with this. We never got it right. I think one of the biggest challenges in primary care, they've got to go and think of things is you'll let me know, I'm sure. But we started off with interpreters, we didn't quite get that right, but then we started to work into that. And as the practice got used to the way patients wish to access services, we got better at it. But it's always just a challenge. I think one of the other things that is a challenge with the is the transient nature as well, which is something which people were used to. But again, it's just that circular learning all the time. So hopefully general practice, we want to change buildings, change services, it all takes forever, doesn't it? So I'm trying to be more reactive.
I've got Lee and then I've got Anthony.
Thanks for that. That was great. Really helpful thinking there. I was just going to make a statement. Really, you might imagine when you're running sort of phone event, the services are doing something. You do something for something in our role about what we can do to get. So even if you've got quite a lot of structural advantage, it's very hard to navigate through it because there's something about how we support those sort of events that bring multi-professional, multidisciplinary people together to go, how do we think about this in a more formal way? So I just want to make a statement really about if you kind of fall into those sorts of events, it's really important to think it's not really the service you do in the team, it's something you do together. How we connect together.
I've got Anthony, then I've got I have seen you, Lisa. Anthony, then you, okay?
I it really resonated for us in Doctor the ERT population to the extent that we've employed two link workers in Doncaster. Quite a similar role to what you described there. My point built on Lee's really is that under a new world, we've got to think very closely about how we support the people who are actually bringing those things together, because the benefit is, I'm sure it can be measured, but it's also immeasurable in terms of the work that's being done for that community. And we need to demonstrate a different way of evaluation to support people like Martina and Helen, the DRT workers in Doncaster, to continue this work, because to retract from that would be going significantly back. That's the challenge.
Lisa.
Thank you, Piers. I just want to say thank you, Katie, Martina and Helen, for bringing that to us. It just shows the difference that you can make in the community when you know your community. The innovation that comes from that is priceless. And I just think we're going into so much uncertainty. I think for me, I'm just mindful that we remember these partnerships that we have going forward and we prioritize them in our new normal going forward.
Thank you, Lisa.
I think for me, we talk about neighbourhood health, and we talk about community health, and there's lots of words written about what neighbourhood health would look like. And it's important to remember that we've got community organisations embedded already in defined areas, and actually the work that CLP is doing, they've been doing for a number of years. So we shouldn't look at the new and shiny, but support community organisations who are already embedded in, because the work they're doing isn't just the health work, it's
Gavin, do you want to finish up?
Yeah, so I'm Gavin, I'm Chief Executive at NHS South Yorkshire, but just want to thank you for coming.
Yep.
for sharing your kind of insights. I think my first observation would be the experience of Roma people and some of the issues you describe around health inequality, access to services, etc. I think speak to other communities as well. So I think there's kind of general learning here. One of the things I was really struck by though was this issue of trust, and I think there'll be distrust will have built up for good reason over many years. And I think formal organisations like ours trying to rebuild that will take an awfully long time, I think. But I think organisations like yours, which are acting as a bridge between formal organisations and the community, I think is really, really critical. So it's just to say, thank you for what you're doing, because I think that's incredibly important. It's something I think we couldn't do it on our own. We need trusted partners basically to work alongside our community. So thank you.
Yes, thank you very much. Thank you again. Lovely to see you. And I will circulate the video around. But I thought it was better that we had a discussion around that. Thanks, Helen. Casey, thank you again. You're welcome to stay, but I need to tell you it might be better if you left. It's not the most interesting thing. Thank you very much. Look after yourself. Okay, next agenda item is Chair's Matters. There's clearly a number of things around ICB reorganisation stuff, but given that we've got a session later on that, I won't pick that up now. I just wanted to report one conversation, kind of relevant in terms of the conversation we've just had. I had with the EDI leadership group yesterday. It was yesterday. And clearly, a whole set of questions are likely to be asked around some of our EDI work over the next few years. And I think my view is it's absolutely right that we could continue to do this. If nothing else, the conversation we've just had with the Roma community showed that to us. I think we also need to think about how we make this about the way we do our proper business. It's not a bit on the extra, it's not a bit on the side. This is about our agenda around equality, around effective healthcare and involving communities. We've sometimes assumed in the public sector, but certainly the NHS, that it's EDI, so we just do it because it's good. I think over the next 2 years, we've got to make this case continually. This is about doing our normal health business better. That's why we're doing it. I think that is important it might be important over the next few years we continue to make that case, because I think it will be needed. So just a point from a conversation I had yesterday with the EDI group, which I found enormously helpful and actually built on a Roma community. Nothing else from me, you'll be delighted to know. Chief Executive, your report.
Thanks, Chair. So I'll just pick out a couple of things. I will touch on the kind of change plan within the NHS briefly. But I mean, start with a bit of good news. I mean, I'm interested in the presentation we just heard about the Roma community. The connection with employment was made, and I'm pleased to say that as a health and care system, the relationship between good jobs and good health is absolutely clear. It's one of our priorities, and one of the 4 bold ambitions that we set ourselves as the integrated care partnership. So really pleasing last month to see the launch of the National Trailblazer and Health and Growth Accelerator by Liz Kendall, the Secretary of State for Work and Pension in Barnsley. And this is a programme of work which we've received £18 million worth of funding. It's a partnership effort with authorities, the mayoralty, NHS organisations, voluntary sector. It's a great example of the system working together, but with the bold ambition to support something like 10,000 more people back into work or to remain in work over the lifetime of the programme. And given that about a quarter of working adults within South Yorkshire are not economically active, and the importance of a good job with good health, I think this is it's a really important step forward. I did want to kind of mention that up front. Just on, I do cover in my report the changes to the NHS, so I think probably it is worth touching on that. So back in the middle of March, we heard that NHS England would be subsumed within the Department of Health and Social Care, and at the same time, we learned about a change in the role for ICB, but also a requirement to reduce our operating costs by 50%. And on the 1st of April, we received some more detail around that. So in essence, in terms of role, the ICBs are being asked to focus particularly on strategic commissioning. So at the moment, we do some other things in terms of system oversight, some regulatory responsibility, look at performance. We have a system leadership role, and we also deliver some patient-facing service like continuing healthcare, safeguarding, TEND, etc. But the proposal is that those other aspects of the role will diminish over time, and the focus will be primarily on commissioning. And in terms of funding, our operating costs would include what we call running costs, so things like our commissioning role, for example, the board, but also programme costs, which are those more facing, or at least the pay costs associated with those services, will reduce from a total at the moment of 55 million down to 30 million. So it's a significant change in our role, but it's also a significant financial cost reduction that needs to be made. So this week, NHS England published something called the Model ICB, which is more detail around the future anticipated role of the ICB. And in terms of the work we do, there were sort of three categories. One was growth, things we'd want to do more of. So I've mentioned strategic commissioning. Now, to do that well, we need to focus on things like population health, strategic planning, the nuts and bolts of commissioning as a payer for NHS services. So there are some functions we want to grow. There are some functions that we are being directed to adapt. So some of our internal governance arrangements, for example, to service the organisation, but not in a sort of system strategic leadership sense, but simply to service the needs of the organisation. And then the final category is things that we would transfer. Now, clearly, some of those responsibilities, some of events like safeguarding and TEND would require legislative change to allow us to transfer. And also, clearly, we need to have conversations with partners, whether that's NHS England, or other neighbouring ICBs, or providers, about taking those functions on. So there's a lot to work through. Now, in terms of next step, we're required to produce a bottom-up plan describing how we'll meet that new set of requirements at less cost by the end of May. So there's a really tight timescale, so we're working through that very, very rapidly. And the expectation is that the new arrangements are implemented by the end of December, which is a very, very tight timescale. And within that time frame, clearly there's a process of organisational design. We'll need to work out how the organisation needs to be organised to meet that request. There will be a need for formal consultation, not least of which with our employees, and then implementation, which clearly, given the scale of the reduction, we currently employ about 850 people, but we would expect 300 to 400 colleagues to exit the organisation as a result of this change programme. So it will require a programme of redundancy as well. So a significant change. But just finally, it goes without saying that this has a massive impact on our people. So we're working really hard, one, to support our people, to communicate. We've got a weekly written briefing and a weekly sort of on team, in person, using that medium briefing, and we'll continue to engage our people in this process. But it is a massive change, and we're also keen to emphasise the kind of welfare offer, support colleagues who will naturally feel extremely anxious. We'll also work with partners in the wider system to see if we can obtain skills and experience within the system. I think that is challenging because NHS England are going through their own reduction, and NHS provider organisations have also been tasked to reduce some of their back office functions as well. I think the final thing I would want to say is we're also working really closely with our partners, particularly at PLACE, because there's a huge amount of terrific work happening as a result of those partnerships in Rotherham, Doncaster, Barnsley and Sheffield. So we're keen to engage with whether it's the VCSE or the local authorities or our NHS providers, primary care, etc., in a conversation about how do we maintain that momentum, whilst at the same time acknowledging that the ICB will have a different role as a partner within that partnership. So I'm conscious we've got a bit more detail coming up later but I think it's important to just share some of that, you know, in the public space, in the public meeting, or a meeting in public rather. Just a couple of other things I just wanted to pick out. Slightly more positively, really pleased that we've managed to secure £7 million worth of capital from NHS England to support development in mental health services, particularly to tackle out of area placement. So these are people who require an admission into a mental health service, but you know, where there may not be capacity locally, and consequently they receive their care more distantly, which is a poor experience for them, a poor experience for their families. We're really pleased that we've got a number of projects now running to increase physical capacity as part of our solution to that particular challenge. You know, Piers touched on EDI in his opening comments. I'm conscious since the last meeting we had the UK Supreme Court ruling around gender, and clearly we're waiting for the guidance associated with that legal ruling, and in terms of what that means for the way that services are provided. But I think it's also really important to know, I mean, I guess for our own colleagues, particularly from, you know, who are themselves transgender, that you know, it's really important that we continue to be an organisation that values difference, and that we welcome people as colleagues in a way that allows them to be themselves at work. So, you know, it may be that there's been a change in the law, and clearly we'll respond to that. But I think in some ways, I think we probably need to work harder at keeping that sense of everybody feeling welcome when they come to the work, and value for who they are. Just a note, just to bring people's attention, we agreed at the last board meeting to adopt the new national eligibility criteria for non-emergency patient transport rather. And to be frank, you know, part of the focus on that is to encourage more people to attend hospitals and for appointments using their own means, and to reduce the amount of NHS provided transport to those with the greatest need. But we are listening to feedback and comment that we're receiving, and we're engaging with the Health Oversight Treatment Committee, also across South Yorkshire, as those new arrangements coming into play. Just a couple of final things. One, just to note, seems slightly ironic now we're talking about a reduced role for ICB, but we actually expanded our role since last time we met, and we've taken on responsibility for commissioning a range of specialised services. So about 70 services which are currently commissioned by NHS England are now being commissioned by NHS South Yorkshire for local people. And I think finally, and again, this seems a strange thing to pick up, but I think it's really important, particularly in the context. So, you know, I'm sure colleagues are aware that the ICB went through an organisational change about a year or so ago, which was focused just on our running costs at that time. And as a result, you know, I think again that put our people through very trying time, and the consequences of that were seen in the staff survey for that year, which we saw a deterioration in morale and engagement and all of those things. And I was really pleased to say that through the work that we've done collectively as an organisation, all of our people working together, that we saw a significant improvements in our staff survey result, both in terms of morale, engagement. The performance was better than most ICBs. It was significantly better than the previous year's performance. And I'm just conscious that, having said what I've said about organisational change, there's a danger that that's overshadowed. But I think that's a huge sign of the commitment that our people have made over the last couple of years, trying to help us do the things we want to do for our community. So I do think it's important to put that on the record. It would be easy to overlook that, given the other things I've mentioned. Thanks, Peter.
Thanks, Gavin. And we will have a session later to talk about what we need to do as an ICB to respond to the reorganisation. David.
So there's something that was announced yesterday, I think probably worth sharing with people. The British Medical Association has announced it's going to ballot resident doctors again. They're going to ballot their doctors between the 27th of May and 7th of July for further strike action. That's in direct response to, they say, a lack of an acceptable and timely pay offer for the 25-26 year. So people haven't spotted that and talked about them. That's something that keep close eye to.
Yeah, and it would be worth, David, very helpful, thank you. It would be worth, because resident doctors do different things, and I think it's worth just painting a picture, not necessarily saying, but when we've got results of the ballot, how many we've got, what they do, because it's quite different from what it used to be, and that might be worth painting. Thank you. Any other points? Moira?
On halfway's work that the previous
Yes.
presentation, are there opportunities in that trailblazers to actually support people in the work from a range of different communities? I think that's really important for us to analysis. Support that.
Christine, you want to just?
Yeah, absolutely. So one of the key focuses of the Trailblazer side of helping people farming being active. So if those people are in farming active, then there will be a focus to the activity. And then anybody with a health related or the health and growth accelerator, so we'll try and wrap those things together around the individual. But we are working with other organisations, community organisations within the different places to try and make sure that we can engage well with
And identify people.
One of the remarkable figures I picked up from the presentation, which was genuinely fascinating, was the age profile, which is nothing like the age profile of our communities, and we haven't got enough young people ready to go to work. It was absolutely clear. You think this, surely we can join this up in a different way, because it was fascinating how many people were under, was it under 20? Fascinating compared to the norm. Very high, and actually potential to get them into work. That's what we should be doing. Greg.
Very quick comment, Christine, maybe all over it. On Pathway to Work, something about being very pointed in employers, both NHS and local, like that. How many jobs would take on? Because that's a bit crazy. We'll come and quite right.
Quite right.
We need to be responsible for that. Making those opportunities available.
Absolutely. And we were,
Yeah.
The NHS is still the biggest employer. It's not other employers. This is the NHS. Thank you. Gavin, thank you very much. Questions from the public. Andy, where are you?
Yes.
There you are, sorry.
Couple of questions. So, first question from the Sheffield Tribune, touching on what Gavin said about model ICB. So, can we confirm that Sheffield ICB will not be merged with other ICBs? How many staff savings are planned for the ICB and what is the delivery? So, there were no plans for merger between NHS Yorkshire and other ICBs. However, we are working with partners to explore whether genuine functions would help us deliver the challenge. The headline reduction nationally is 50% of running costs and programme take-off. There have been some adjustments made for local practice, but particular population sizes served. The savings need to be within the envelope of 18.26 ahead of population, and the reduction in cost is to meet the target by the end of 2025, 26, usually at the end of this year. And then the second questions were from Alex from Commercial, and this was about the NHS supply chain framework in the context of medical procurement, prioritising how we get savings to implement in the planning guidance, and in essence, the ICB's work on supply chain framework does not identify a specific framework, and we'll post a full response to that to Alistair and on our website.
Thanks. Okay, thank you. Item 9, agenda item 9, board assurance framework and climate risk register. Mark.
Thanks, Chair. So the board assurance framework and corporate risk register is presented to the board for consideration and approval. I'll take the documentation as read. It highlights our kind of key risks. The thing I would highlight particularly is really that over the coming months, we'll continue to operate our risk management and corporate assurance cycle. But I do think that in light of the really significant changes to the ICB strategic and operating context, we need to take a view on not just simplifying the BAF in relation to how it's constructed and taking on feedback from our audit colleagues, but also to reflect the new operating context and the risks that are presented, both in terms of our 25-26 operational and financial plan and the organisational change programme itself. I think over the coming months running through to the summer, I think that there's a job for us to support the board to do some re-evaluation of the principal risks for the organisation. Yeah.
No, I think that's right. I mean, let me be slightly more blunt. You know, by the end of the year, calendar year, we will expect to have reduced our staff numbers by circa 50%, and our accountabilities will have narrowed significantly. So, for instance, I don't see how we could maintain risks around accountabilities that are nothing to do with us. Now, whether they're picked up properly by DHSC is a different matter, but we cannot possibly take some of these accountabilities going forward. The question I think we've got is how we drop them over the next few months and ensure that at the very least the Department of Health are aware of their responsibilities. So I would expect, if you like, by the 1st of January, these are far narrower because we actually won't have the staff to do them, and we've been told it's not our responsibility. And there's a task for us all to look that through. And I think as the role of the ICB becomes clear over the next few months, I think it's a piece of work, particularly for non-exec directors and the committees, to say, actually, this is no longer our bailiwick, it's somebody else's. So that's something we have to do, and that needs to be in place certainly by the end of the calendar year, the revised risk register. That makes sense.
Just a point of actually on that report, because the report will be on Word. I wrote this on that sort of financial Word. No longer will get all my fault.
Thank you. Any questions on that? Thank you, sir. I think there's quite a bit of work to be done outside the board, be presented back to the board towards in autumn, and certainly be completed by the end of the calendar year. Okay, moving on to the next set of agenda items on improving outcomes, population health and healthcare, involvement of the. Gavin, are you interested? Casey.
Thanks.
You're on again, Casey.
Endeavour to be quick and claw back some of the time I lost earlier.
Oh, that was no.
Again.
No, but actually, it was a really good discussion, genuinely. So
Yeah.
don't worry about that. It was great.
Thank you. So just as a bit of background again, you'll recall following the Start With People strategy refresh, we agreed to bring regular updates on involvement to board because it was something that our citizens told us they'd like to see as a demonstration of our accountability for involvement. Before I go on, just to give a bit of feedback from Helen, who, as I saw her out, just wanted to say thank you. She felt that some of the other things that we put in place on the back of the Start With People strategy refresh, like the opportunity to invite Shahida and Leslie to the meeting, some of the support that Helen in my team's given her, and then bringing her to this meeting has given them a voice that they felt they didn't have before. So that was really good feedback to hear. So just a couple of things to highlight. As before, we started the paper with what people have told us has influenced our work. I think it's fair to say it's still a work in progress, this bit, because it's about embedding it throughout the organisation. Otherwise, my team are just constantly chasing people to find out what's happened on the back of the information that they've passed on. But I have included some areas where we can show that we have influenced already. Then just to say, I've given a few examples of the work that my team's done supporting programmes, projects, pathway redesign, involvement, but we have recently completed the involvement annual report, and I've put a link in there. So I didn't want to recreate, reinvent the wheel and include loads more of those in there, because if you wanted to have a look, there's loads of examples of how we've supported that and made sure citizen voice is embedded in that in the involvement annual report. The things that I've given a bit more focus on are some of the bigger pieces of work that we are using to transform our systems and processes to be the best they can be and really embed citizen voice and reducing health inequalities into our work. Really pleased that we've got a go live date for the Insights Bank of the 19th of July. So that's been a couple of years in the planning. Training for my team on uploads is happening next week. Then we'll have a period of user testing. We'll do sort of a bit of a marketing push to remind colleagues across the system about the bank and what it can achieve if we all work together on it. So, but we've been doing over the past 2 years, we've been doing loads of socialising of it, and people are really positive. And I think it'll be a really good thing for making sure we are hearing the voices of citizens in a continuous way and using that to influence our work. There's also been some really good impact assessment activity happening. We've reviewed our processes, we're continuing to evolve those, but we do have really good feedback nationally on our impact assessment approach, and we're really starting to see some really fantastic, well thought through examples of impact assessment in our meetings, and they'll be a really key tool for helping us reduce inequalities. And then I just wanted to just give a nod to the work that's ongoing with the deaf community, because obviously we heard from them in November. They're feeling much more positive about their involvement, particularly in Doncaster. So I think that's really good news. They're really feeling engaged in the audiology work at UBCH. So I think that's fantastic. Still a long way to go, because we still hear things from other deaf BSL using communities in other parts of South Yorkshire, but we're really raising the awareness across the system, and I think that's having impacts. What I often find when I go along to meetings and sort of flag some of the issues that the deaf community faces is that nobody's excluding them deliberately. It's generally just a lack of awareness and thought about the fact that an intercom doesn't work for a deaf person, or an audio, calling system doesn't work for a deaf person. So making some good progress there. And then finally, just a nod to the partnership working of the team. As always, we've been offering plenty of support and guidance to provider colleagues, both in primary care and across the provider collab, to help make sure that they're on top of their legal duties for involvement. And then a mention of the community of practice, which people are really welcoming. So that's a network of about 120 people from across South Yorkshire who were involved in or interested in working with citizens, and we co-design the approach. There's about 40 people attend the meetings that happen quarterly. We brought the Clifton Learning Partnership to the last one, and so they did a really great piece to help people understand how they could better involve the Roma community in their work. So that's it really in a nutshell.
Casey, thank you, Azama. Any questions for Casey? Thank you, Casey, that's grand. Place partnership updates. They're done in alphabetical order in case anyone thinks we're special. We're doing people differently here. Casey, do you want to start?
Saying I'm not special.
No, I just know I'd be criticised by three others. Just three of them.
Thanks very much for giving us an opportunity to update on the Barnsley place. And I think I had feedback from the board last time that I hadn't celebrated a big opening or event. So we've started with Liz Kendall's visit to Barnsley, which is obviously part of Gavin's report, also reported in terms of the trailblazers, getting people back to health and back to work. It was a really, really successful event. We had some really good kind of questions and answers within the audience that was kind of there to be around as the Secretary of State was there, and a really good starring role from our very own Christine on the kind of health trailblazer work, and managing to get, I think, Liz into the headspace of saying actually health is as important as getting somebody back into work as having a job. No, sorry, got the wrong way around. Having a job is a critical part of getting somebody healthy and back into work. So really, really good event. I'm really proud to be part of the South Yorkshire. Noted in the report as well some of the outputs from the Call 25 work, which is a kind of core part of the neighbourhood approach we're taking in Barnsley. I'm really pushing the work that we've got being undertaken on health and assessment, which is obviously important, and high intensity. So just noting that and thinking about how we build out from that with the partnership work that we're doing at the moment. Noted too, the Dad Pad app from Barnsley Hospital, which is helping new fathers with a range of support that they can get both locally and nationally. And then the final one, the Great Childhood Ambition, was also launched in Barnsley. That is across Barnsley partnership, really trying to focus on engaging with our families and children and young people about what they believe they need to have a great life in Barnsley. And a key element of that, which I know is also spreading out across the rest of South Yorkshire, is free bus travel, which is starting in Barnsley for young people, with a range of rules about behaviour, not expected, but free bus passes enabling people to travel to different parts of South Yorkshire and also obviously to travel hopefully to gain different experiences and education. There are loads of stuff going on as expected. I was just very briefly then going to touch on some of the work that we've been focusing on to improve performance in Barnsley with across our partnership. So huge effort was put in with in Barnsley Hospital to the people within that 4-hour target and a really, really pleasing achievement of 80.2%. We've also seen a real push on our virtual wards, which is key to our continued work to achieve the non-elective reduction of people going into hospitals that we need, and a lot of focus on how we ensure that we maintain that 119% occupancy that we were seeing through South West Yorkshire partnership as well. We also kind of reconfirmed, as each of the place partnerships have, our priorities moving forward, and as well as all of that work that we are doing on flow and how we might prevent people going into both our hospitals and adult social care more expensive placements. We've confirmed that we will be focusing on how we work together in neighbourhoods and use those as a key part of the work that we're doing in the borough, how we develop our integrated neurodiversity service offering. So lots of work going on, and I think, as a couple of colleagues have said, part of the challenge that we are working in within the place partnership is how, through all the changes that we know we're facing as an ICB, we keep hold of some of these valuable pieces of work. We know we're going to need to focus down on some of the things that will make the most difference to our city and our city. But just a really, really clear vision, I think, for Barnsley, to try and make sure that we don't lose the brilliant work that's been happening.
Okay, thank you. Any questions, Katie? Doncaster, Anthony.
Thank you, and here. Doncaster report focuses on 3 areas today. One is cancer prevention, second is primary care, and third is women's health. They are all areas that the Health and Wellbeing Board have identified a key area of focus across our partnership and our Team Doncaster approach. In terms of cancer, start with 5 great campaigns. Doncaster's lung health care, great campaign across South Yorkshire shows up. We still have around 53% of patients diagnosed at stage 1 and 2 of cancer against a national 75% target, and we still have quite a significant way to go in Doncaster and indeed in South Yorkshire. So some of the things that are on that first slide, which I count around a combination of around 15 to 20 partners involved, are all aimed at awareness of an engagement with our population around cancer prevention, timely presentation. There's some great work in there that you can see around our Roma and traveller community, from our patient story, and a range of engagement really. But I would just echo Kevin's point that this is the sort of stuff we cannot lose, and we need to really work through that and bringing all this work together. So I'm really proud of the work that's going on in there. In terms of primary care, we've always been clear in Doncaster that we want to put primary community care at the forefront of our place plans and our partnership work. It should be noted in Doncaster that there is a period of flux in leadership in primary care across our city. We've got a number of new footprints for primary care network, and there will be a change of leadership in our primary care federation going forward. That makes some of this work all the more important that we maintain it. Just to quote a few of those, we have around 180,000 appointments a month in Doncaster, and our reception and administrative staff are the face of those appointments. We had a session with 180 staff last month. A lot of that was around learning from best practice around improving access and some of the things that we're doing around digital. But just as crucial is the peer support that those staff have, particularly related to the increase and in terms of incidents of abuse and indeed crime in GP practices, dentists, optometrists, pharmacists at the moment. And we are hearing from this staff, not just in Doncaster, but across South Yorkshire, that we need to do whatever we can to support them in that unfortunate climate that we find ourselves in. We've had some talk with Primary Care Alliance. I've had some initial conversations with Andy about what we can do really in this space, particularly committed to a public campaign around respect, responsibility of residents accessing primary care, and having to work with partners on that and bring reports back to the board. Carrying on with primary care, I was really encouraged to see that neighbourhood health was still emphasised in the model ICB work, and we're ahead of the game, I think, in South Yorkshire in terms of the work that we're doing. Again, I would say the clue is in the title, neighbourhood, and place partnership approach in Doncaster is our Thrive work, which is going great guns. More than keen to ensure we don't lose that under the new world. So our neighbourhood health where it's at, we need to still have the ability to bring partners together on that. And then finally, I'm really happy to say that our long planned work on our primary care hub in Bentley has broken ground. And now that the election is over, I can also say we're ready to go with our health hub in Roddington. That's 2 new modern health facilities used by wider partners in 2 of the areas of Doncaster that need it. It's been a long haul this, but I'm really proud now that we've got to make such a difference for those residents. Finally, a focus on women's health. To our shame in Doncaster, really, women in Doncaster live 56 years of age in good health. This is the 3rd lowest nationally, and it compares to a national average of around 64 years. Therefore, the work that we're doing around improvements in women's health right at the top of our health and wellbeing priority. The report documents some of the fantastic work of primary care colleagues and making particular use of our health van, again targeting our most deprived community. Finally, it would be wrong for a place report not to mention the seismic event that happened in Doncaster last week that signalled a real change for the city. I'm of course referring to the crowning of Doncaster Rovers as champion of the PFL League 2, and congratulations there.
Very well, Fred. Rather than Chris, I don't think you follow that. Particularly if it would be nice to support you. You cannot follow that.
So, thanks, so Robert. So, 4 things I'd just like to pull out the report for the time, if I may. So, first one was what we've learned over the last few years. Is if we're truly going to make a difference in health and ecology and health, then we need to treat. Sorry, Leslie, you talk about the whole person and not the So what we did is we had a one-stop shop event, which is a community appointment there. Just give you a picture. We've got patients accessing community services, mental health services, working with women, legends, looking at the whole makeup of what they do. It's a model that seems to work really well. We'll keep exploring evaluation of the team. In terms of initial evaluation, next thing I just want to talk about is our urgent care centre. So for those of you who are not familiar with Rotherham had a brand new urgent emergency care centre in 2017. Even now, that is not as we would wish it to be. So what we want to do is, if we really want to make a difference to improving health outcomes, patient experience, and also financial efficiency, the model we're using is same-day emergency care. So patients that would have historically would have been quite frankly admitted to hospital. So now the department should be in a way which allows patients to so again, we've got 7 million Next one. Can you, this is 29, this is how long? Boris Johnson. 2019, South Yorkshire received 57 million. Enable our core places to have modernised. Rotherham had 2 surgeries selected as part of that. One was really late, which I reported previously. Second one is Waverley Housing Estate, it's on the board of Sheffield. Brand new housing estate, you know, 5,000 to 6,000 residents. I cannot tell you how hard it is to get a deal to get. You've got local authorities who have to own the building. You've got treasury where you've got to get business stated. You've got building firms who want to part of the bigger development. And then if we practice to run it. And so the ICB goal is to bring all that together. It takes 6 years, quite frankly, being relentless is allowed to get over the line. And I'm very proud to say that our outstanding social enterprise gateway is providing services to the way we get an amazing service. But it's had a soft launch, it's local formally again. And lastly, and not this is all more good news, it all involves capital money we've received in terms of mental health division. The biggest ambition I have personally for Rotherham and for Doncaster is the share mental health stuff. It's got no mental health academic placement. You know, quite frankly, the bad experience and we've got funding for our 16th unit, which we dedicated to Rotherham, Doncaster, and South Communication. And what that allows to do is to have a fitness environment which is autism friendly. That's got all the sensory ones which I think we have. But most importantly, it allows us to have a local service which cover. So actually, quite good news actually. Yeah, so I'll pass over to Sheffield.
Thank you. Emma, Jeff, thank you for it.
Well, looking back in last week, that my other place director got uncovered lots of stuff that we actually really grew. That's helpful. So just for those who don't know, we've got 7 priorities and at the last health my part of the board we agreed after the meeting intention for the next 2 years, which is really helpful. One of them being same day urgent care. So again, we've been doing some work with our partners, we've been looking at what public funds around same day urgent care, access to primary care, walking centre, etc. And we're now in the process of developing the final spec application which will go out to all providers on the hope that we can develop an integrated service and really start to, I suppose, remove the duplication and really get to talk about, you know, people understand what the right care, and that's not the case. We're hoping with a new local assessment service being part of it and working together as providers to really get into it. So we'll see that we'll develop over the summer. Neurodiversity is one of our priorities, and again, it's great to see all the blocks that we can actually make, although we've still got around our waiting. There's a lot of work partners on really trying to improve the patient experience. So we've done things like put more speech language therapy in the city, and we've been working with Sheffield and other partners really start to think about what we can do. We're holding people on the waiting list, but we're also redesigning the autism pathway and the ADHD pathway, which I think will really start patient behaviour mental model or a clinical model. But we know it's a huge issue for our children and people, and we need to do more on it. So great to see that kind of focus. Again, Chris has already mentioned good work. Thanks, Boris. Again, see the progress from Sheffield. You can see there, pictures from our new development again. The most important part of our city, looking to put more than just healthcare in there, looking at working partners, and again, that's well. Sheffield Lane Disability Health Desk, again, you can see there. Again, this year we've been really successful in making sure that we've got people in for those checks, and that physical health is also being again, and my team works really, really hard. That we know people with learning disabilities have and look for outcomes in accessing healthcare. So our absolute relentless focus on that target is really important. Some of you may have seen Panorama that looked at the assistance general practice, one of our practices, and again, you know, we know there's lots of evidence to say that people have one long-term condition. If we work with them at a neighbourhood, at the local level, actually we can really start to prevent them
develop in the future, long-term conditions. So again, that work that we've been doing that practice, we're looking to learn and share in other practices. Focus then on waiting care again, we know the impact the carers have as well, in terms of providing that support across the health and care system. So again, doing loads of work for health companies, and there's some partners. Then Kelly Home been doing mentor because again, you know, the class back that with it, and definitely plan. So it's absolutely crucial, and exactly what we do to have something like this on our doorstep. So that's really all I was going to say. Oh, the other thing just to mention is that our no criteria for that we can today is the lowest thing in the last 2 years, 12%. Reflection on the team working together in a great way. So, you know, with 22% when I first started, now 12%. Yeah, you know, we need to hold it, but it gives me hope that by working together in a great way, we can really start to improve the health and well-being of our population.
I agree. That's a real achievement, Emma. Should not be underestimated. So well done, you. Any questions for Emma on that? I think.
Question, but we have, because the state has been featured so heavily in all the place reports, have the announcement yesterday around additional funding from the department in terms of primary care estate and enablement of 8 million more appointments as a result. I think it's fair to say we just need to work through what the detail might be for South Yorkshire and what our approach will be. I don't know why I'm looking at you, Liam, whether you have any more.
We don't have any more detail now that you announced. But what we have done is we've done quite an extensive sort of lessons learned piece of work around everything around primary care, identifying
Slow, painful, isn't it?
How would you explain that whole national procedure to now give it out now, how we use that sort of lessons learned where we go, if you're wrong, it's out further, really take the time. When you run around an individual project, you will learn about how to do this, go along, so we'll focus and think about that. But the impact of that might be South Yorkshire, we're not, what it's not yet.
Okay. Okay, thank you. Agenda item 12, independent mental health homicide review. Are you introducing this, Chris?
No.
Sarah's here. Hi, Sarah. I saw that you were.
So, good morning, colleagues. I'm Sarah Gould. I'm the Portfolio Director for Mental Health in the ICB, and I'm here to update the board today on the mental health homicide review. So, for people who might not be familiar with this, this was the incident that happened in Nottinghamshire, where Valdo Calicane unfortunately took the life of 3 people. So, just I think some key points for the board to know. The first would be the extension of our condolences to the families and loved ones of those who were affected in that incident. We did discuss this paper at board in November last year, and I think sort of building on some of the themes we've heard today around inclusion and mistrust of services, it's really important that people don't take what happened as an opportunity to demonise people who have a severe mental illness. They are people who have multiple vulnerabilities who really struggle to engage with NHS services, and we have a duty to meet their needs in the best possible way that we can. So really important that we focus on continuing to support those multiple vulnerabilities. Since we discussed the incident in November, all of our provider trusts have undertaken an extensive amount of work on their action plans. So this was around a maturity assessment that they did, looking across all of their services that might interact with people who require an assertive outreach way of working. There's been a lot of work within the trust and with system partners, so some support from NHS England colleagues and our mental health, learning disabilities and autism provider collaborative. All of our mental health LDA trusts will be discussing this incident within their respective boards as well. One of the things that we've also done since November is work with the Clinical and Care Professionals Assembly
So this is a range of specialists across mental health and autism, as well as some general practitioners, to review the maturity assessments done by each of our trusts and the action plans that have come out of that. It's really helpful to do that and have some of that independent view on what we've been put forward. We have come up with some identified learning and support, and the Clinical and Care Professionals Assembly are going to help the trust to work on that throughout the coming year. I think at this stage in the review process, the ICB remains partially assured that we can meet the needs of these vulnerable communities. The major barrier to full assurance for us is resources, and it comes at a time of significant financial challenge. You will have seen in the paper that the resource required for us to fully meet the needs of this community, which is heavily around workforce, is in the region of about £4 million. So it's not an insignificant barrier for us to overcome, but we are looking at other opportunities that we can do to work together across trust to make sure that we're supporting this group of people and with other system partners in local authorities. So basically the ask of the board today is just to note our position, note the ongoing work across our trusts, and just really to encourage you all to advocate and support our mental health learning disability and autism services to meet the needs of these really vulnerable people.
So, thank you.
Just to follow very quickly, so thanks, Sarah. We are formally required to have this at our board, aren't we, part of the national process? We would anyway, wouldn't we? But just so people know, every ICB.
And presumably, as you were saying, Sarah, each of the trust boards are going through much more detail of those. Greg.
Thank you. Did help report quite sobering in all the way to my bet. Just an observation, I would guess that this kind of stuff wouldn't count as strategic commissioning. It needs to be done, and it doesn't happen by magic. So your point on resources and sort of delivery implications is given, but someone, somewhere, somehow, across multiple organisations, has to be the convener to bring all of that together. And if that isn't strategic commissioning, then who and how? And I know we don't know the answer.
No, I mean, I think there's a number of things on the agenda today where you ask exactly the same point, Greg. Well, that doesn't look like what we do come January the 1st. Who's going to do it? Mark.
Yes, I'm fairly far. The conclusion of the information you can share with us, I think it's certainly helpful for members' knowledge. I think, how can we preempt something like this happening? And it's what are the warning signs, and I think what the feeling is something that not. Is a dashboard that maybe looks at, for example, people that have regularly not attended appointments. It may give an indication of people who engage in services. Another challenge that we can about an operation responsible for delivery, and maybe on occasion operation eventually bear that in mind. I'd have to end what Sarah was aggressive about national local focus on the mental illness. At the moment, so we make sure that we're able to retain that level of focus. And I think one of the challenges that was raised about who is responsible for discharging people that is doing effectively. Maybe not the quality of that as well, coming up at a level of
Thank you. And for the members of the public, Mark, Chief Executive of one of our mental health providers, is on the board. Thank you. Moira.
Good point. In terms of the recommendations around the review of down on improvement. So I'm just wondering whether that will be goes into the next phase of work, and also linking to that. Again, the recommendation around voice of people with experience and family carers on this. Making sure that we actually hear the voice.
Great, Moira, thank you. Richard, you want to come in?
or not. There's a bit about how we make sure that we're actually joining up to various aspects of that plan. So that we don't end up with something that is in the store, that there is a core ICB service.
I can answer that one. So we agreed with Cumberland North Yorkshire ICB that would cover the North Lincoln path, that the report will come in via our board in South Yorkshire, because the majority of the trust is within our path. However, the paper has been shared with them for discussion, and their mental health lead attends our South Yorkshire quarterly reviews around this. And likewise, Swift colleagues of the other Barnsley part of within our path. Again, my equivalent for West Yorkshire is in, so we're trying to make sure that we're cognizant of those borders.
Kathy.
Yeah, Sarah, I just wondered what learning we could take from the approach to safeguarding in this space, that's in relation to that multi-agency approach, MASH, information sharing, and that is just something that can be taken out of that into this space that really supports that sort of identification of vulnerabilities, but also all the stakeholders being aware. It was thought really.
Well, clearly there were lessons here about, you know, I think you said it, well, you know, when somebody doesn't, one of the things trigger or say, we need to intervene. It's not good enough not to let them come and not turn up. And that's, I mean, you know, really it's complex stuff, but it's actually really important. And that the essence, some of the essence of this is right in the heart. Lee.
What's happening next? Actually, now we've all crocheted together the resource information that we want to find. We're going to find I'd be the more defensible folks by the nationally we're now actually approaching those resources to go. There's different ways to do this. Or we're not going to be in this situation, are we? Being told no more money, but to implement the findings in time. Being missed out, the resources required that we haven't got available to us. Do we understand what happened nationally?
My understanding was it's been pushed as part of the spending review, but I don't think we've got any assurances that what will come out of that might meet the risk.
What I think is here at the board, we do need to ask that open question now. We've now got identified for us, this is what you be compliant with the national action plan. We've been told the national peer do the things that you can do without resources at the moment. We didn't ask the open question about what's going to happen next. That could be validate those costs, look for better practice nationally, or find the funding for. Just being left with well, you should really do this, but we can't do it.
I think that's right. Can we pick that up outside? And it might need to come back to the board to a legitimate point. I agree. David and then Kathy. David.
So that was exactly the conversation we had at the regional quality group, and one of the escalations from that was to be fed into the national quality board on how can we square that circle. You know, we've got an action plan, but the resource along the line.
And presumably this is the same picture in most ICBs, I'm guessing. So, Kathy.
Yeah, I mean, I would imagine that this will hinge now with the inquiries that's been launched because the families were unhappy with the outcomes and the outputs of the independent review. So I think it'll sit somewhere in that space. But just from that government point, I just wonder if it's worth us thinking about how we capture the outstanding risk without that.
I think it is. Can I say though, if it's awaiting a public inquiry, it will be awaiting years. Sorry, I'll state the obvious. They do not report anything under about 3 or 5 years, in my opinion. So really helpful. Thank you for that. That was great. Okay, we now have a break for 10 minutes. Comfort break, and then we come back. And we are on time. Everybody get silence. That's quite moving. Just we're going to agenda item 13. Agenda item 14, the cancer update. A couple of people are due not to attend till midday, so we'll leave that agenda around. We'll probably come back to that later, just so that you know when you know. Okay. Agenda item 13 is performance. Sarah, you'll lead me through this, yeah?
Thanks, Kate.
Right.
Just as normal then, I'll do the operational today. I'll then hand over to David Happy, anything from a clinical perspective, and then Chris can put the work forward.
Thank you. Thank you, Sarah.
Thank you. Just in terms of context, this is obviously close to the end of the year in terms of finishing off. So a lot of the focus has been on planning and where we start, where we started in terms of April and April performance. So I'll reference some of the planning through my update. So in terms of urgent care, then against the core standard, we finished 75.1% in March and target of 78%. That was up 0.8 in the March previous year, which is a lot of improvement given the size and scale of the effort that has gone into getting 0.8%. I think we've already referenced Barnsley and how well they are. I think what we've done to kind of bring urgent care back into focus is we had a workshop on the 17th of April with the key items that will get across the urgent care performance. 75% still means vulnerable people are waiting over 4 and hours there is significant challenge for the urgent care. Urgent care board focused on it, workshops as they happen, and then the board the action. In terms of ambulance, then 21 minutes in terms of the ambulance handover for March, which is a significant improvement. All 4 trusts have signed up to the ambulance 45-minute handover policy that starts with the rollout in Kitchen on the 2nd of June, moves into Doncaster mid-July, and then Barnsley and Rotherham in this time. So that's significant. It's a significant sign of intent. I don't think we've got all the action plans yet in terms of delivery, but the fact that we're implementing in the summer gives us the opportunity to work with that for the winter, which will be more challenging. So absolute intent there in terms of the ambulance handle time. Cancer, I'll just leave that. We've got the update later, but it's normal FDA see 2 days, challenge. And had some challenges in our other providers as well. So in March, Barnsley has been challenged to deliver the standard, and we've had 1 or 2 halfway people cancer isn't. In terms of elective then, 65 weeks where we finished at the end of March, and I know we've still got validations going on, but probably end up with 30 patients waiting over 65 weeks at the children's hospital, all of which is specialist stuff that can't be done elsewhere. 150 patients in Doncaster, and that was a mix of nearly 50 ENT clinics, and then Sheffield is 80 patients and some SPA, and that's neurology, but some gynae and specialists. That number we've got a lot less for their specialists in terms of things like endocrine and complex surgery. So there's some challenges there. Good news on 65 weeks. It is no longer standard for the 25-26 operating plan, and both of our organisations have been taking that during Q1. That doesn't mean that there's not significant risk in there. It means that actually, from a clearing perspective, they're measuring the amount of patients over 50 and we like line basically using our challenges. And we've agreed from a Doncaster perspective, actually, it would have been helpful, that we'll continue on a fortnightly basis, tripartite, ICB, NHS, and the trust to work through the challenges and hopefully get those through. So, good news on 65 weeks, don't underestimate the challenge that the city going forward. In terms of primary care, then, you can see all the data in there. I think the big plus is the dentistry, where you can see on further faster. The downside to that is that that's the operating target for 25, 26, if I get the numbers right, for the stretch target, and actually the non-recovery delivered this year means our stretch target is undeliverable. So we've been ahead of the pack, we've done better, and actually been clean out because of it. In terms of mental health, then again, all of the issues, out of various placements, numbers in the past, there's initiatives, we've already heard about capital investment. The other big push that we've had this month in out of various placements is specific work around family health and social care, where we've done the place has done a lot of work in terms of the things up, and that has been brought down again, not to where we want it, but to more 20. ADHD was still not impacted by the only information that we've got. For the first time ever, we got those factors in selling last month, recognized as a whole of the product, which is why they're not in the law and in this report. But there was a group in that group that we wanted more information. And we're going to have a deep dive into ADHD and the neurodiversity stuff. So I'll stop there. That will probably highlight from the operational perspective. Happy to take any questions.
Thank you. Any questions?
I'm reviewing the grid portal and it has come on link about the information there. I am looking at it as a relatively well informed member of the public. I'm going, what is it? Absolutely now. This is reports might be that, but I'm just getting through what's it telling us where are we forming the country, where we need to conversation energy about national data, probably getting about what measures have or could impact on some of these indicators. So I'm just kind of thinking out loud. So it's in really good shape.
It's in really good shape as from where I came in.
Yeah, great.
It's an overall indication. I think I would be much stronger in terms of rolling it out. My intention also was to look at that over the summer and review and not for that time and energy worthwhile spending at the moment. The other thing we've done is look at NHS benchmarking to see whether we could put some comparative data in. There was a cost associated with it. So I think these times are finding out thoughts that haven't gone through my mind, and I think it will need. When you be mission intensive, you mean specific mission, you still need all this stuff. Yeah. So I think there's something about how is it more and how does it move on, and I don't know the answer to that. But I don't think we've ever sat here in a performance management perspective. I think we've sat here in terms of performance improvement head on. So I think we do need.
Moira, then David. Moira.
Thank you. I was going to make some points around benchmarking, but just not your point there about a cost associated with getting that benchmarking data. Is that something worth it further? I mean, I've got it there. It's I did it in early March, and then March hit, so I've kind of put it in a file. But I've felt more comfortable looking at another end, which I thought when I did.
Aren't we getting? And I've seen several versions of league table. These are my words. League table. Don't smile like that. They're really German, and which is what you're looking at. And I wonder whether we should think in the future about putting them in our package of information we give out.
So being well informed by NHS that I can't remember the correct term, but it is table F in terms of how it's going, starting to unfold. Well, they're already nationally putting together in-day performance reports. Yeah. So NHS now, I think you get a pack every week with the in-day performance going out. And I know that there are conversations happening in March between Secretary and provider organisations that are in the performance. So well, I believe that is the case. So yes, there is definitely a movement.
Yeah, I just think routinely that should be part. If they're becoming public, they should be routinely part of what we put out. Thanks, so Dave.
I was going to go into my bit, but if I could just respond to that, I think we need to remember as a board that we do have a number of assurance committees and other things that look into the detail. So there's something about the IPRs capturing everything we do.
No.
and actually we've kind of gone from a massive report that just had lots of stuff in it to something that I think is a bit more readable.
Yeah.
I think it's always going to need a bit of commentary by those that are leading the programme to give confidence or assurance,
Yeah.
whatever it is the board are looking for. But that's just my view.
No, I think that's right. Richard, and then
Mine's directly related to the last week.
Yeah. Yeah.
And one of the concerns that I think a number of people have been you wanted the general reduction of food waste by offering choice of provider and a single food, yeah, you are less likely to, you know, so there was some counsel really in terms of clear what it is we're going to have to do and clear what the enablers are for collaborative partners working. We need a great working partners as much as possible as partners for
Richard, I happen to agree with you, but I think the trend is going the way of league tables and individual trust. I'm not sure that you're right. I'm not sure it encourages always the right behaviour, but this feels like an approach that's quite transactional. It's quite contractually based and league table based. And personally, if I was running a trust board, I'd really want to know where I was on everything. And secondly, if that's the public, we need to see the information as well. I think just because Kevin.
I'm a great believer in less is more.
Yeah.
Very careful, of the emphasis of what the should do, but otherwise, the intervention could have.
I agree.
At least we're going to need that. You might be working. What is the solution? How do you remember that? Whatever guy.
Yeah. Really helpful. Anything else on? David, do you want to come in on the policy stuff?
So just
Thank you both.
three areas, please. So Sarah's picked up some of the urgent elements. We're still waiting for the national reform document that we expected alongside the planning guidance. The word on the street is that it's not going to be ambitious enough, and we're still looking at performance that is a way off our pre-COVID positions. And I think from a clinical perspective, that's where we want to get back to. So we await that. Gavin highlighted the national eligibility for non-emergency patient transport. I don't think as a board we should hide behind the fact it's been quite a difficult month to implement that, and we've had a number of inquiries and complaints which we are, investigating, and we will continue to work with GAS to refine the process. But the other element is what's the offer alongside that. So we're having to go back to what's the healthcare transport provision, what's the alternative. So I think to be absolutely honest, I think that's worth noting. The second one is on paediatric cardiology, and in the middle of April there was an announcement that the Secretary of State has appointed Dr. Camilla Kingdom to do a review of child hearing services. Personally, I think that's a bit late. Should have been done probably when the Lothian report was published. However, I am pleased to say that actually from a South Yorkshire perspective, we're well on the way of kind of investigating, knowing where we are, and actually improving the services that are there. So I think that we've still got a bit of work to do, but I think that I wouldn't be fearful of that. I think we're on with that. And finally, looking at one of our biggest pillars in South Yorkshire, cardiovascular disease, and pull out that Emma referenced that learning disability annual reviews. And actually, if you look, our learning disability cohort for hypertension are better than the general public levels. I think that's to be commended. I think that really shows the value of if you target interventions, you target specific groups, you can reverse the trend. So I wanted to just highlight that as a positive within the report.
That's a really good business like Kathy.
Yeah, just a couple of points from me. There's nothing to sort of escalate to the board, but I think just picking up on both Lee Morris and Kevin's point actually that I think we've lost some of that. So I think some of that data was in. So what's the national average? Kind of particularly looking at some of the maternity data. I think we've lost it, and it might be the language that we use. So what the standard means. So there's probably just that in there, and again, kind of reflecting on what would I want to know if I was sat around the board from a non-exec perspective is actually what progress have we made towards some of those national state ambitions. So they were around reducing stillbirth and acre mortality, etc. by 50%. I'm not sure we're on a journey of improvement where we are as a system in relation to meeting that. So that's just kind of reflecting that short space really. I think as Richard articulated that power of working as a system or collectively together, I think is really evident in the maternity space, and what we talked about at our last system board, maternity board, around how we really pull through some of the outcomes related to that, because that probably isn't what we capture here as in the real improvements we've made around pathways and outcomes in relation to that across the system. What we are now focusing on is the preterm birth pathway. So we've done lots of work in that population health space on the things that should help reduce preterm births, but we are still seeing a sort of gentle rise in that. So just doing some really specific work on that, working with through our NNBPs and our service users, just in trying to understand that and what a system pathway might look like in a much more proactive way. I don't think there was anything else I was particularly going to pull out at PS, to be honest, other than I think kind of a reflection on what we might be looking at in the future.
Yeah, and I think that is something we will need to return to. Any other, Kevin?
Yeah, thank you for questions today in the context of the summary hospital. I think at the last meeting we talked about progress on technical FY, South Yorkshire ICB mortality and death. How has that progressed?
That's difficult to meet for the first time this month. So we are reviewing the data, but that more established part of our clinical governance is still on trend. Got support from some of the councils to do that. The good news is that actually the work that's been undertaken at Doncaster as the outlier is actually showing that actually they're no longer an outlier. So that was our last discussion. So that's good news as well.
Lucy, sorry, before.
Just make a comment about the one that we're not shying away from, and that and come back with reviewing technical. Just a couple of things. One that I think there's still work to be done around information, both information about the new criteria, but also about one of the mitigations being access to the low income, and I think that information still isn't out there in a very accessible way for a lot of people. The second point is that to acknowledge that some of the kind of fix that we want to make in terms of movement mean that some people won't be able to access health travel costs. Some services that previously they might have access in a hospital that have essentially been moved out into the community setting. So this is an example. We did some work around pulmonary rehab groups, which are brilliant sessions, really improved without some ongoing conditions. People have been using patient access those group sessions. Potentially won't be eligible for patient transport anymore on their position, but also aren't able to claim health travel costs for that particular service because of the criteria that are applied to being able to claim that back. So that's just an example, but I think it's recent services and think about how those travel and every bit of work we do with transport and
Okay, Point well made. Can we return? I think it is right about returning to that, as we said we would, in terms of, you know, well, what's the experience? And the bit I hadn't thought of, Lucy, so thank you, is as we make shifts to the community, which on paper are a good thing, we might actually, you know, unwittingly create transport difficulties for people. So I genuinely haven't picked that up. So point well made. Leslie.
Thank you. Yeah, I just want to explore what Luke was saying, and in fact, I've made a note for myself to say that once it's embedded a bit further, I think it's something we need to do back quickly, just to look at
I agree.
both in terms of things that are falling through the cracks, but also I was interested in whether we've seen an increase in do not attend
DNAs,
and things like that as a result of it, and what do we understand about it? Okay, you know, we understand why we have to do it, but what's the impact in terms of clinical health when we can't get things, they're not turning well. So I think it is something we need to come back to, but we need to give it a bit of time to see.
Leslie, that's really helpful. I'm happy that that's done through Quippy, and then you come back here when we've got more. Dave, do you want to come back? Sorry.
Just only briefly to know, so the ambulance service who currently have the contract for West Yorkshire, who went live last week, and North Yorkshire are going live this week, I think it is. So I think there's a commitment to have a moment to pause and reflect on as across the whole of the Yorkshire ambulance service. So they within liaison with me last week. So I think all the points relevant and listened to, and bring them back.
Thank you. Yeah, well, I'm happy that Quippy have a good look at it first, Leslie. So it comes back here after that. Anything else people want to raise? Thank you. Thank you for that. We're going to delay agenda item 14, as I've said. I'm sorry, Christine. I'm sorry, I apologise. Yeah, you did say that. My fault.
So, I mean, just following in a similar vein, really, I mean, on the NHS organisations, the trust, which is what this paper is presenting, not the whole of the health and care with. Fitness absence rate, I think that was one of the things I wanted to talk about. It's like we have, but it isn't recovering, it's really improving. We're still higher, you know, reasonably significantly higher than back in 2020. So there were always approximately 500 people down in comparison. Obviously, that's therefore driving some of the costs around contingent workforce as well. So, you know, in the spirit prompted by Lee and things as well, what are we actually doing about that? You know, there's quite a lot. We're trying to find where there's areas of good practice where we can make a real difference in short-term fitness absence. I mean, it is a national issue, this, so we are trying to do that performance improvement stuff and have a look for that. We do have a health and wellbeing roadmap that covers the whole of South Yorkshire, so we are looking at things like prevention activity. We're working with Health Innovation Yorkshire to understand if there's any evidence that this can help health and care. I just wanted to flag that. Just on Richard's point around not looking at this just as a trust lens, in the work we've been doing on the medical agency spend, particularly last year, but it will continue. It was interesting to note that if you just look at your own data, get used to where you are in your own data. So somebody said to me, I always look at mine, and my workforce is always lowest in terms of. But when I presented the aggregate data, they could actually see that they were actually higher than most comparative trusts. So there's something about seeing your benchmarking data that helps you put, you know, yourself in the right position rather than looking in things that I would really support us being able to continue with that lens.
Thanks, Christine. Any questions on the workforce? Thank you. I'm sorry. Okay, I said we'll take cancer later, so we're moving on to the financial delivery report, Lee, if I may.
Okay, this report summarises your fine. So, the morning back, our homework and how we put together our year-end position and the audit looks that. The summary position is the ICB in 24-25 delivered a deficit of 38.3 million. So what that formally triggers a letter from our external audit. Our core duty around delivering financial value was not the key. So we're not alone with that number of people a month. Notifying in our core financial duty. So we delivered that 38.3 million deficit position. That's compensated for by an 8.1 million surplus in provision for the South Yorkshire NHS system with the net deficit of 30.2 million. The report just explains what happened in the 2024 financial year plan versus actual, and then what happened in this year's plan versus actual. We'll go through the audit process now, but I'm not
Thank you. Any questions, Leona? Okay, so let's move on to, on the basis of that, move on to the next agenda item 16. Great, thank you.
And we'll have the planning submission that was submitted on the 30th of April.
Which we discussed at this board anyway, a couple of days earlier, if I remember rightly.
There shouldn't be any real surprises in there. In terms of any acceptance, that's been a draft letter, which we're expecting to say that they accept our plan, recognise the risks that we've highlighted in that, be that finance, be that cancer, be that dentistry, in terms of the risks that we've replied already through the system, and they know they just want some overview of our financial governance and our PMO report. So in terms of NHS, we've almost got the letter across the line in terms of sign off of the plan. In terms of the operational target, all of those more of analysis in there. We didn't see that at the 11th hour updated projections from STA did look that they hadn't thought much about winter and how the activity was going to profile, so we managed to correct those. We also had a long discussion about ambulances and ambulance handovers in the 15 minutes, and where previously our organisations had all signed up to that, the other organisations in Yorkshire hadn't. And we were challenged on where we bring all the evidence. And they've got a very hard time into that. So we reviewed that at the 11th hour and all, well, BBTA, STA and Rotherham put in trajectories that are in line with other trusts across Yorkshire. So about the 20-minute mark instead of the 15. Again, still very ambitious. In terms of next steps, then I think there are two things we've still got to do and we'll speak to IAs. We've just got to make sure all of that's done, the impact assessment, and we've also got a piece around governance that we're just taking through to make sure that all providers are taking their plan through their provider board to make sure that we've got that goal over cloud and that's what it's doing. So from an operational perspective, I don't think there's anything in there that can have it already things at the hand pause.
Thank you. And we did go through those figures.
The summary of the financial section of the presentation outlined what since we submitted our February draft plan and last stage had a forecast plan deficit of 100 million and how we managed to close that gap. The details that explain how we closed that deficit across the organisation. In South Yorkshire, there was a specific exposition on the things we now need to do, what we to deliver the balance plan and the work for everything else we need to do. Choice work is trying to track down how we remedy excess of patient care and work on distribution service. I think the plan for 25-26, I'm betting that it was 24-25. I'm saying it's still doable, or at least understand all the headings of the work in order to deliver a balanced plan. When I'm talking about 4.5, about sort of 49 million when I identify we don't want to do it. But it balances the plan this year. I'm not saying it's going to be all the things we've got to have choices, disposition of service. I think we've got a clear understanding of that across the system. Moira and I meeting with the chair for the plan, making the executive organisation on Friday, just run through that to make sure we've got a common understanding of all of that. Obviously, this is well rehearsed in the executive space, but we're just about making sure all the balls that we've got well. This is the actual work we need to do to deliver a balanced plan of the system. The efficiency target broken down by place, the value detailed work on the ICB budget, signing them off, and we'll go to the sign off of the budget. You can have the finance committee in June. Identify as next step for the ICB budget. The main thing that's happened last week is we met first time with the board, talk about the things that we're going to monitor absolutely in this system place with the equity with it in organisation. Or the work around demand mitigation, the work around difficult choices, the work around the strategic drivers of benefit, how we're approaching changing how we deliver services. We agreed on that interfaces with all that work. So we have a pretty light reporting question on one, not we don't know all the data we need for the ICB reporting. We'll look at what that looks like later this week. The monthly report, and then in the sort of years, I'm sure there'll be a huge amount of emphasis of on or off plan, both at an organisational and at system level, as we go through the year. Everything that I would claim, we've got quite a lot of risk in all of these plans, because the NHS in not really our own. I might make a claim, and it might be large person, like what we need to do. There is a huge amount of risk in how we'll be able to do it.
Question. Couple of things. I spoke to all the chairs after we put the, and I was genuinely reassured by how knowledgeable they were about what was required of them. I hope to get the same from the finance committee. The chairs were really clear on. We had detailed discussions about demand management and all that stuff. They were on top of it, which is it should be like that, but it's reassuring. And I guess the other thing is increasingly we will be monitored on our budget, not the budget of the provider unit. So I mean, I guess the finance committee really need to be on top of that in over the next month. So get really on top of what do we have to do, and have we done it? What would yes.
There's a lot of work to Chris, Sarah, myself, and other clients. There's a lot of work going into the but I think we've got a much clearer picture of how we want to get our business from 17 million one day.
Yes.
So versus how and what we do in that. So I think one of the good things, but I think we're clear in that one. About what bit that focus on it. Fantastic.
Yeah. And that's the bit of we need to be right on top of the detail from. Any other questions for us really help? Oh, sorry, you did want to come and Gavin.
Yeah, sorry. So I agree with sort of Lee's comment about the quality of the plan. I think the process actually get to that plan, the engagements of provider organisations, etc. I think has been much better this year. I think that's much more collegiate process, and coming up with a plan that allows all of the organisations to achieve balance, I think is a significant step forward. Slightly obvious point is, I mean, given the changes that we're facing, there is something about acknowledging that risk, but at the same time not allowing that to derail us from delivering our aims, both in the system space, but also the 96 million that the ICB has to achieve. That's easy to say, but difficult to do, but nevertheless, that needs to be our focus. I think there's also something, when we messaged the System Efficiency Board last week, I think there was an acknowledgement around pace. This is a demanding plan. There's a considerable degree of risk within it, and it's an obvious point, but we're already into it. So there's a sort of recognition that actually progress needs to happen at pace. So it's slightly blatantly obvious, but I think really important to note.
Yeah, no, I think it's a point well made. We don't want to find end of quarter one and think, oh, we didn't realise we were flipping that way. No, I agree. Have we all seen that? Have we not?
That's the end point. We received feedback on the plan.
Yeah.
High risk, medium risk, lower risk for it. Favours of the individual. system. And I thought about it, about it, plan overtime work on, and about how do we do that.
Okay, helpful, thanks. Item 17, specialist commissioning update, delegation update rather. Lay that into you.
Absolutely. So as Gavin noted, very cool. We met the joint committee between the four ICBs in North East Yorkshire. There are a regional team that are still administering the work around the specialist portfolio. What we're trying to get right is the line of sight of that joint committee, both the ICB and the board. So we're trying to do something that's additive as opposed to duplicative, just about bringing out the information from all ICBs. It's very good that we managed to whisk around the delegation. We've got a clear line around this around the commission portfolio. At some point, it might be useful to have a broader conversation development session about the line of sight, especially portfolio, and how we do that really well at the board level. To be honest, is a bit of outstanding we're about to do that really well at the executive level, but we're not really duplicative with the joint committee. So it's landed, hooray, but there's a bit more detail to work out to make sure we've got our oversight line. That portfolio, both executive and the board.
No, I agree. I think it is something we need to return to. And I'm happy to say, you know, we did say land it safely from the 1st of April, task 1, get it operationally working, task 2, and then think about reporting, task 3. I'm happy that when you two feel comfortable, you come back here on the task 3 to come here. Kathy,
yeah,
and then
a quick question, Nick. Who is quality representation on that oversight? Or that joint committee commonwealth?
So it's got the current medical director and the director in the regional commission team. What I think we need to check is what's the line of sight with quality oversight of all ICBs. And I think there's just a balancing act between what we've got within every versus is actually more assured. So in exactly the same way, we're having a bit of angst around the financial oversight. So I've heard before, this is the finances of the ICB, including the delegated commission portfolio, but I'm talking about how we get this into business as usual, candidly, without overwhelming the former regional team doing the work.
Yeah, and there is something as well, given our changing role, about not introducing an over-reporting mechanism for 4 or 5 months that we scale back. That looks to me, that's counterintuitive, isn't it?
Live conversation about overtime, we provide at least staffing that will both do the overtime delegated and the right action. I think that is a very mind about what very good point. Without this staffing although now we're all that means more globally about connecting with part of it and we have own contributions about how will we do it.
That's helpful. Thank you. Moira, and then
Just a quick question. I mean, obviously recognising that there may be change in the future, but I'm just wondering where the sort of level of their local authority input to that making absolutely difficult of some people within the facilities are very complex needs where funding from both joint funding locally and specialised assistance.
We want to set up a point of currently done together the four using all the children before we've got around the services now to the oversight to what additional or oversight might help. It's probably been a service by service.
Very, very helpful, but there are some very complex.
thanks, Moira. Let's go to Anthony.
So, colleagues know what I'm going to say. We are still due to receive delegation of public health teams and responsibilities to the ICB from NHS England from April next year. We were bang in the middle of planning for that. There's been a little bit of a pause, as you can imagine, in those conversations. We need to get back into it, though, in terms of what that might look like. There's a little bit of an element at the moment that who would come, what would be the responsibility, and what would be the responsibility of the ICB in that going forward. It is worth saying, though, that while we continue those conversations, there is a risk at the moment. There is a vacancy in England. There's a number of vacancies in those teams at the moment. There is the ability to do the delegation transfer well as we go through the ICB, and of course, what's it going to look like in the future. So I just want to flag the board really that those conversations that continue with NHS England and our local ICB, but inevitably does come at a risk on making this land well.
Is the intention still to land this year?
Yeah.
Because that,
Yeah.
that doesn't feel like our. I mean, I understand that we've inherited the specialist commissioning, and it probably couldn't be stopped by the time the Secretary of State sent his delightful letter about it. And it is commissioning. You're right. Get that, but it feels to me like to devolve this to us from April next year, when it might not be our responsibility from January next year. I'm a cynic. Doesn't feel the most intelligent thing I've heard, and I have heard something that I've read. But can we just? I don't want us to be. I've seen the civil service where we end up on a track because they were told to do it, without realising that we've changed. I think it's worth us asking a bigger question. Okay, that's right.
For example, we were expecting to that has now been called. We have to do that. And we'll go from to formulate overall their role.
Okay, that's fine. I just think I want to make sure we don't do something that everyone looking at it would think it's bizarre. Greg, I'm sorry I delayed.
Anthony, if he's my interest, I'm more than happy to put the first one and work into that one. So backing in, I'm broadly okay with screening and work out. Well, I'm more than happy.
Thank you, Greg. Okay. Anything further on that? Thank you. Corporate insurance, agenda item 18, I apologise. Corporate insurance for ICB governance. Mark, I'm sure this is you.
Thank you, Chair. Just a number of things that I just like to highlight to the board. So the corporate insurance report is the standard report. It's presented to the board for just confirmation of some key corporate activities. Things I'd like to flag are the corporate seal has been red hot this year. So I've never experienced anything like it. But I would flag that all of the uses of the seal have been to support the primary care estate development work that has been talked about in the updates from our places. So that's quite satisfying to see that. In terms of the rest of the document, we highlight the work of the committees of the board, and for the first time for the formal executive group, which is the executive committee that the board constituted a number of months ago, you'll see there's also a link for board members to access the decision log, the primary care decision log, which relates to our responsibility for primary care decision making and the delegations that have been made to us and that support the work of places. And that's there just to close the loop for the board so that you can see how the board, the duties that the board has delegated to the various officers and groups have been executed, and it's for the purposes of audit. And so I can now formally tick that box. There are a number of policies to ratify, and they're highlighted at Appendix B of the report. I won't list them. I'm sure you've all read and followed the links and have appraised yourselves of those. And finally, the Finance and Investment Committee terms of reference presented to the board for final approval. They've been through the process. So that's it. Peter, rush through that.
Yeah, can I just say to the board, we are still using a bloody seal. Am I the only person in the world who thinks in 2025 that I am signing documents with a seal on them? I thought that was, Tudor. It's extraordinary. I must have signed about 8 in the last. I mean, maybe it's just me. It is just me. Okay. That's still utterly Byzantine. You all go, yeah, of course, yeah. Every other document I know, including major legal documents, my family's full of lawyers, they're doing it online between each other, and we use it.
The same.
Yeah. Oh, it did the same. Oh, yes. Yeah.
A bit more modern, if not black.
No, you laugh, it really is.
We don't use candle white. Can I just clarify? And it's very modern.
Really? Okay, thank you very much. That's sorry about that. I had to whinge about that. We still haven't got Kirsten Acres, not 12 o'clock, to be fair. The only probably worth picking up agenda item 19 before we go back to cancer. Technically, this does need approval, doesn't it? Do you want to just talk us briefly through? Do you mind?
Yeah, I'm going to just have a very brief introduction. So the National Risk Register has been published, and you won't be surprised to hear that cyber is quite significant within that, particularly threats to the health and care system. Average impact score is based as moderate with a likelihood of happening of 25%. So I think we don't need to look too far afield, do we, in the news the last week about how retail's been impacted on this. So I guess that's a bit of just to raise the profile of how important it is. But here,
Thanks, David. Yeah, so bringing it a bit close to home in terms of health and social care. So I think a couple of years ago, the National Cyber Strategy, health and social care, sets out how we need to improve our cyber resilience across health and social care. And as a result of that, anything on that ICB work to convene, design, implement a cyber strategy for each ICS with the requirement to submit this in 25-26 England. The response to this requirement, we, the ICB, have worked closely with South Yorkshire partners to develop this strategy, and it's outlined in the papers. Just a couple of contextual things, and so to be clear, the ask is for approval to disseminate the strategy from England, and as I guess as a response to that ask, but also to implement the initiatives set out in this strategy, working closely with South Yorkshire partners through the South Yorkshire Cyber Forum, recognising that delivery of the plan and timescales will flex relative to the funding that we receive from the Department of Health and Social Care, which we're hoping to hear about imminently, and also notwithstanding the model ICB work. In the paper, you will find details of the strategy that was co-developed with partners across South Yorkshire through the Cyber Forum, and that includes NHS and local authority representation. There's also a drive diagram in there which sets out the initiatives that we hope to deliver in order to reach our goals, and the high-level delivery plan, which, as I've mentioned, will flex relative to funding availability. Final point to note is that the strategy has already been supported by NHS Executive Services Leader, Executive Review, and in terms of determination out to partner organisations, we've already shared it with Chief Information Officers, so we provide delivery board, and we will be preparing a standard comms toolkit to share with partners so they can share that within their own local governance as well.
Thank you. People comfortable with that? Thank you. That's good work, Danny. You have a feeling this problem is going to grow and that we're going to get more, regardless of our role in this, Kieran, this is going to be real scrutiny over the next few years, given what we've heard over the last 2 weeks, even the retail. So thank you for that. Really helpful. Okay, I'll just find out. We'll try and find out where Kirsten is, and we'll go back to cancer. Are you okay with that, Emma?
Yeah.
Welcome, nice to see you. The truth is, no one expected me to be ahead of the the board. Can we just note that? I think that'd be really helpful.
I will do, thank you, Emma. Yeah, so for those of you who don't know me, I'm Beth Byrne. I'm one of the associate directors in South Yorkshire Basketball Cancer Alliance. Julia was supposed to be here, but unfortunately, she's not able to, so she's kind of phoned me in at the last minute. So
Nice to see you, and don't worry, we're dead, Jack.
The Cancer Alliance covers South Yorkshire basketball, for those who don't know. Chaired by person who will be joining us shortly. I'm being followed officer from the ICB for cancer. I think we've got two roles in life. One is a strategic commissioner, so that's useful for the future, and the other is around delivering things as usual. And there are a number of issues in relation to increasing incidence of cancer, workforce risk, and diagnostic capability, which we will talk you through. We must know the link to the integrated care partner strategy, which is one of the COPA's key priorities as well. And also the Show Up campaign to talk about, which really is about cancer in everybody's business. One of us will sadly get it. So the presentation really talks us through what we're doing in relation to some of those elements, but it really helps us hand over to you. Well, can you move closer?
oh no, that's a bit bigger. I think my about going through. Oh, thank you. Okay. So, yeah, as Emma's just said, I just wanted to kind of utilise this time to talk through the presentation, which just brings out the key bits of the paper that's already been circulated, in terms of the deep dive into cancer. So, if we can just, thank you. So I thought it would be useful to start with some context of where cancer is today, both from a kind of a national and a local perspective. So, cancer is the UK's biggest killer. As Emma said, its incident rates are rising. 1 in 2 people will be diagnosed with cancer during their lifetime with at least one cancer. The number of new cancers are rising per year, and from a UK perspective, it's expected to be rise by a fifth over the next 20 years, so that's not insignificant. The number of people living with cancer is also increasing significantly due to an ageing population, increasing incidence, and increasing survival. So with the number increases, as kind of the analogy from the back perspective, people will increasingly be living with multimorbidity, where cancer is just one of several long-term conditions. And while it's predominantly a disease of the elderly, actually what we're seeing now is there's increasing evidence in the younger population, particularly bowel cancer, with emerging evidence that it's actually linked to a lifestyle in terms of those younger people. Oh, next slide, please. Thank you. So as it says, 1 in 4 cancers in the UK are actually preventable, and there's a number of risk factors that are common to all cancer groups, and also that they're related to other long-term conditions. So not surprisingly, these being smoking, obesity and alcohol. And as the data gets updated, we expect to see the rising impact of obesity and alcohol, and like I said, the emerging evidence with regards to bowel cancer in the younger generation. Cancer is a significant contributor to life expectancy gap in South Yorkshire. It represents the greatest gap in terms of life expectancy between the most and least deprived areas for females, and it's the second for circulatory conditions for men. Next slide, please. Thank you. So I'm not going to go through the whole lot in terms of from the presentation, but incidence and mortality rates for cancer across South Yorkshire are significantly higher than the average for England, with 18% higher incidence rate in the most deprived areas. Lung cancer is a leading cause of death in South Yorkshire and Bassetlaw, and more people are diagnosed through emergency presentation than the national average. We've got worse outcomes for people with a learning disability, people with a serious mental health illness, and those from an ethnic minority background. So with incidence rates rising and more people living with cancer, we need to work towards turning the tap off, like Bath analogy, and what can we do to do things differently, particularly with 1 in 4 cancers being preventable, and lung being one of those, particularly in our area. And we want to look at a life course approach, and we've started on the journey with this with our partnership strategy to determine what are the key points of influence within somebody's lifetime, and what's the impact of primary, secondary and tertiary prevention, alongside obviously the importance of screening and that early diagnosis. And as Emma said, I'll pick up the approach that underpins our Shows Up public health partnership strategy, which we're working with Cynthia and Oliver Coppard on. I'll mention that later. And given the growing demand of incidents and people living longer on our services and the need to take this life course approach, it's evident, obviously, the impact that this is having on our cancer performance and the difficult challenges that we're having in South Yorkshire. So just to give a little bit of context for those who aren't in the kind of the devil of the detail in terms of cancer waiting time standards. So in 2023, cancer waiting time standards changed from there were 8 constitutional targets, and they've now been moved to 3, and they're kind of consolidated measures which represent key stages within the whole pathway. So the first one of those being 28-day fast diagnosis standard, which covers the diagnostic phase from GP referral to rule in or rule out of cancer. And it's really important to note that that's kind of the measurement point is at the point where the patient is informed. There's a 31-day, which covers the treatment phase from decision to treatment, and that is the agreed date with the patient. The treatment start date for both first and subsequent treatment, and it incorporates things like surgery, systemic anti-cancer treatment, radiotherapy, active monitoring, and palliative and supportive care. And then last but no means least is the 62-day cancer waiting time standard, which covers the whole of the pathway from referral, including screening and consultant upgrade, to the start date of first definitive treatment. Slide, please. Okay. So, as we said, in terms of rising demand, and nationally, there's been a 25% increase in urgent suspected cancer referrals from 2019 to 2024. From a South Yorkshire and Bassetlaw perspective, we've seen a consistent year-on-year increase of 3%. In particular, tumour sites such as skin, urology and gynaecology, we've seen significant increases in people coming through in terms of those pathways from an urgent cancer perspective. We have seen reductions in some areas such as lower GI, and this is linked to successful implementation of things like, and I'm going to try and pronounce this, fetal immunochemical test, which is fondly known as FIT, as people may be aware. But actually, and it said it on the kind of the previous slide, to note, and it's incredibly important, that less than 1 in 10 people who have an urgent cancer referral actually then go on to be diagnosed with cancer. And there's also a number of our cancer patients who are on routine pathways prior to diagnosis, so it's not just around the urgent cancer referral kind of pathway. So in 2023-24, 62-day pathway, so a 20% increase. 31-day pathway, so a 12% increase. And alongside the rising demand, cancer pathways are becoming increasingly complex, posing an even greater challenge to achieving the 3 constitutional targets. Elective and cancer pathways are drawing on the same capacity, particularly from a diagnostic perspective. And there's an additional reliance on getting kind of rapid diagnostics, staging diagnostics, as well as from a treatment perspective, number of treatments expanding in terms of increased specialism and a reliance on things like genomics, which also needs to be factored into increased capacity. There's the growth in new drugs, there's more and more drugs come through, and a NICE approval, which is putting unprecedented pressure on our non-surgical oncology services. Mutual aid, not through want of trying, has been kind of limited, and I think that's due to the particular kind of the reliance on specialised services and having obviously one tertiary centre within our PAP. So mutual aid requires that kind of regional or wider support, but we're not unique in the workforce challenges that we have in South Yorkshire and Bassetlaw. Many other providers have also got those significant challenges that makes mutual aid really, really difficult. So I just thought I'd kind of give a little bit of a brief overview of where we are from a performance perspective and what we're trying to do as a Cancer Alliance, working with our partners to either sustain or improve that performance. But just to note, and Emma mentioned it around our footprint from a South Yorkshire and Bassetlaw Cancer Alliance perspective. So we represent all the South Yorkshire organisations as well as Bassetlaw, but we also have oversight in terms of Derby and Derbyshire and Chesterfield Royal Hospital Foundation Trust, and that's because of the patient flows into our tertiary centre. So obviously we keep an eye on that from a performance perspective. So for fast diagnosis standard, it's a positive story. We've held a strong position against this constitutional standard throughout 24-25, and the latest data has just dropped in for March. This shows February, but just dropped in for March, and we're showing a March compliant position against the national 77% trajectory, which is fantastic. For 25-26, we've submitted a compliant system trajectory against what we're expected to have an ambition for March 2026 again, which is a positive story. Next slide, please. So whilst that is good and compliance against the fast diagnosis standard is strong, there still remains a large differential in performance for ruling out of cancer, which stands at 82.8% compared to a diagnosis of cancer, 51.6%, quite a significant gap.
So can you just talk me through that to make sure I understand that? So to rule out cancer, we were 82%. We're doing that within time, but to positive cancers, because they take longer, we see them first, we have another test. I presume that's what we're talking about. So they're more delayed. Okay, sorry, I just needed my head to get around it. Very simple.
And I think there is, into exactly that, Pierce, there is an issue about the complexity of staging, and have you got the Philadelphia chromosome and all of that, can we actually convey the diagnosis of cancer to a patient while we're still doing further diagnostic, but actually, and that's a massive change in kind of 5 years.
But it used to be a kind of, you turn up, X test was done, whatever it was, you got a diagnosis.
Yeah, and I think we've got a cancer event in ST8 next month, but I think we're thoughtful about, we're waiting till the whole battery is done so that we can tell you what your definitive treatment is. Whereas actually, we need to think about changing our pathways where we say, yes, you have cancer, we're not sure what the treatment is yet. You start getting your head around that, and then we'll see you for treatment.
Yeah, I understand the difference. Sorry, I didn't mean to interrupt.
No, that's absolutely fine. Yeah,
I needed to understand.
So specifically from a Sheffield Teaching Hospitals perspective, the Trust has made significant improvements around that kind of ruling out of cancer, which was at 52.4%, but now it's 0.5%, which is a significant improvement. Unsurprisingly, most challenge pathways, which is below the 50% for compliance for diagnostics, are the areas of urology, head and neck, gynecology, lung, hematology, and lower GI. So those are the real kind of significant areas. So just to kind of talk on a few points of the work that's been undertaken in 25-26, and these are just a kind of a few areas that we've pulled out. to really kind of support and sustain that that performance around faster diagnosis standards. So our team have developed a Power BI based demand and capacity tool, which I have to say is phenomenal, that facilitates real-time modelling, and what it does, it supports providers and obviously our internal processes around operational planning for image modalities. So we're working really, really closely with the Acute Federation to trial in the first instance around MRI, but we're hoping to kind of roll that out to different modalities and expand the usage of that mechanism. Again, working with the Acute Federation to look at the potential of a head and neck regional diagnostic service to increase the resilience in this pathway, which is quite fragile at the moment. And also recognising that we can't do this in isolation from a cancer perspective. Absolutely goes hand in hand with the elective pathways, because from an OMFS perspective, we want to have the kind of the best outcomes for our elective and cancer patients in that arena. So there's a focus on standardisation and consistency around recommendations that come out of Get It Right First Time, best practice time pathways, to really look at the reduction in variation, particularly around treatment, and making sure that we've got the timeliness that we expect in terms of those pathways, again, to give the best outcomes for our patients. Inconsistency in the delivery of things like patient stratified follow-up, which is intended also to release outpatient capacity. Next slide, please. So 31 day, not so good news, consistently below the 96% threshold from a 31-day combined treatment perspective, and we've been the worst performing cancer alliance in 8 out of the 11 months within 24-25. A little bit of good news in terms of the latest position that, like I said, just landed. It does show improved position in March, but we still remain non-compliant. There's no operational planning trajectory for 25-26 for 31 days. It was decided nationally to take that out. Challenges from a 31-day perspective and why we're in this position predominantly relate to surgical and radiotherapy capacity for first definitive treatment. Performance overall is actually worse for kind of second or subsequent treatment. And what we're looking at from a Cancer Alliance perspective is really, really looking at the impact that things like new NICE drug approvals are having on that, the options for treatment and those subsequent treatments, to really understand what that impact is having of that plethora of different drugs. Again, the most challenged system pathways are urology and lower GI, and they're very much linked to theatre capacity and non-surgical oncology, and you'll be aware of the position from a South Yorkshire Basset Law perspective around non-surgical oncology. So some of the work that we're going to be forging ahead with in 25-26, and that I've already started some of this in 24-25, is around supporting the urology Get It Right First Time review recommendations. And as a kind of a Cancer Alliance in the system, we invited the national urology GERF team in to really give us some peer support around looking at this kind of urology pathways. And the work that we're wanting to do was particularly around surgical reconfiguration, but that will be very much led by the urology area network that's supported by us through the Acute Federation. So other work that we're wanting to do is specific pathway, capacity and demand modelling, right-sizing surgical and non-surgical oncology capacity. Again, I've kind of alluded to the significant challenges around non-surgical oncology. So there will be a significant focus, again, for non-surgical oncology, both in terms of stabilising the current status and improvement and transformation in terms of that future service model. So that's around consolidation of face-to-face outpatient models across our path, looking at an enhanced virtual clinic offer. And then from a transformation perspective, it's around greater standardisation, repatriation back locally, a new clinical service model, and looking at the potential for a virtual ward which relates to same-day emergency care for acute oncology. We're also looking at, and this links into the kind of the partnership strategy around the development of a strategic capital investment plan. That's actually quite hard to say. And it's all around that capacity of right sizing, and it really supports that acute to community shift, analog to dialogue shift, obviously which we need to work towards. Next slide, please. And next one, sorry. Okay. So 62 days, which is one, I think, of the areas that board were particularly concerned, for want of a better word, about. So throughout last financial year, we were consistently below the 85% standard, and we really struggled to achieve the in-year trajectory of 70%. Some of the challenges relate obviously to the elements that I've just talked about. The late position again that's just dropped shows an improved position in March, but we still remain uncompliant in March, non-compliant. So it was agreed from a regional and an ICB perspective that we were able to submit a non-compliant system trajectory for March 2026. The ambition 75%, we submitted a 65% trajectory, which is predominantly driven by Sheffield teaching hospitals. However, we need to recognise that actually represents a 10% improvement on the position where FCH are currently at, which again is nowhere, we need not to kind of walk past. Next slide, please. Again, 62 positions predominantly driven by Sheffield teaching hospitals who are remaining tier 1 for both elective cancer and diagnostic. Oh, not elective anymore. I can cross that off. Excellent, thank you.
Thank you.
But also need to recognise that actually 62-day performance will be continue to be impacted because the improvement plans that we're kind of collectively working on will be enacted to reduce that backlog. So inevitably, when you're reducing that backlog, and to get us in a much better position and kind of clear that, it's going to have an impact on the 62-day performance. So there is a detailed, really detailed tier 1 improvement plan. It's been signed off through the ICB from a performance perspective. It's been signed off by our regional cancer board, and it'll be closely monitored through the tier 1 process and also through our Cancer Alliance board. There's a few actions, if we just kind of, oh no, sorry, they are on there, apologies, go back one, sorry, my fault, in terms of particularly integrated care board actions that are included in this tier 1 improvement plan, and I'll just kind of read those out, they're quite difficult to see. So that's around ensuring the service development fund with the cancer remains ring-fenced for 25-26 to support performance improvement, ensuring that the focus on cancer performance is prioritising the wider elective improvement plan. As I said, they go hand in hand, and recognise in terms of the activity and finance limitations, to maintain oversight and alignment of risks, including potential harm through Sheffield teaching hospitals, the integrated care board governance route. And this latter action particularly focused on cancer waiting times, not being that kind of cliff edge target, so whether you're either in or you're out. And we really need to understand where, from a quality and an impact perspective, where there's likely to be the most harm caused. So we need to concentrating on performance as well as quality. So from a 62 day perspective, some of the work that we're trying to do to kind of really strengthen our performance position is around progressing the single cancer management system. Well cited on that, which incorporates enhanced tracking capability and proactive patient management, and really kind of aligning the best practice time pathway models, and working with the Acute Federation and the imaging and pathology networks around turnaround times for images and pathology, and things like supporting recovery and improvement schemes with a view to sustainability and transition. And this is around going into businesses as well. So this is not kind of stick and plaster things. This is around really making sure that we've got those sustainable improvements and understanding what the capacity is needed going forward to manage that demand, to manage some of the challenges, and also linking into what, from a strategic commissioning perspective, we need to do going forward, and linking that with the partnership strategy. Do the police know that that's performance done? And I'll talk around on the next slide the public health partnership strategy that we've got with numerous partners and kind of very much led from a kind of integrated care partnership perspective. So noting that incidence and mortality rates for cancer in South Yorkshire are significantly higher than the average for England. We've got poorer outcomes and inequalities across our system, which I mentioned earlier. We've been working with the integrated partnership to develop a cancer strategy. You'll see on all our kind of backgrounds, we've got the kind of the Shield Up logo, and that's very much, the title of our partnership strategy. It's public health led, and we're one of the partners around the table with others to tackle the incidence and impact of cancer together. There's the 5 bold ambitions up there, which are actually kind of iterative. So the intention is that delivering ambitions 1 to 4 actually then culminates in enabling the ambition of 5 of the reducing the number of premature deaths from cancer for people under the age of 25. So it's got that kind of cumulative effect. So year 1 priorities in terms of the partnership strategy. Next slide, please. Recognising the need to focus on primary, secondary and tertiary prevention and the impact that can have for people on their outcomes and the risk factors obviously that are common across not just all cancers but many other long-term conditions. We've been focusing on that kind of prevention and screening element, particularly working with young people and employers to raise awareness, recognise signs and symptoms, support the reduction of risk factors. And from an employer perspective, there's a real opportunity to build on that and the work we've been doing to align with the Health and Growth Accelerator. And there's already kind of conversations that have started in terms of that. So I think that's quite an exciting opportunity to bring all that together. We've got a strategic partnership with Yorkshire Cancer Research around prehab and rehab. The programme of work is delivered by the Advanced Wellbeing and Research Centre, and they're currently developing the case for change around the physical activity, what impact that has on cancer outcomes. And that relates to a really compelling economic case around noting the improvement that prehab and rehab has on patient outcomes and enabling people to go back to work after treatment. And this work links into a wider piece of work that we're doing, and we started in year 1 of the partnership strategy around really developing that economic case for change, looking at the future of financial and capital investment, and again to inform commissioning intentions. So I'm just going to take a very short breath. There's a video, if we're able to play it, hosted by Oliver Poppard, and it just talks around some of the work that we've been doing with employers.
All too many people in South Yorkshire will know the devastating impact of cancer. I've certainly had cancer impact my family, and loads of other families across South Yorkshire will be in that same boat. We're trying to fix that problem, help people to help themselves and help each other. It means people being diagnosed more quickly, it means people getting the treatment that they deserve, it means people being cured of cancer, and it means those living with cancer live well and live longer. All of those things are fundamentally important. Outcomes in South Yorkshire are not great. We have worse outcomes than other parts of the country, so we need to work together, all point in the same direction right across the region to solve that challenge. Employers have a huge role to play in solving this problem, in helping us to work together. People spend most of their lives at work, and so we need employers to help us, to help people to get diagnosed more quickly, to get the treatment that they need, and to live better with cancer. If you live in South Yorkshire, if you are one of our community, then we're going to work together to try and fix this problem and help everybody to live longer, live better, have a happier, healthier and longer life in South Yorkshire.
Thank you. last couple of slides, so I'm conscious that I've kind of talked for quite a while. So in terms of looking ahead to year 2, we'll be looking at kind of scaling up and embedding the work that we've done in year 1, particularly utilising the kind of the data and insights that we've got, really good insights into kind of the areas of recommendation from a kind of a population-based perspective, working with place-based partnerships as we've been doing in year 1 and the voluntary and community sector. We'll really be looking at defining what those partner contributions are from a partnership strategy perspective. Year 1 has been, I think, more led by the ICB and more led by the Cancer Alliance, but it's really, really important that we really start to define what the partner contributions are around the kind of from the ICB perspective. And there'll be a focus on advocacy, starting with the non-surgical oncology pathway, which has been really well co-produced with our patient advisory board, who are, you know, an incredible asset to us. And I know, Gavin, you kind of came and presented, and they're just an incredible bunch of people that support us with what we do. We'll also be reviewing the management of late effects, because we know that they have an impact on people's mental health as well as physical health. And I thought I'd just finish off by, I know that I've pinched that from the kind of the model ICB, and just doing a little bit of reflection in terms of the work that we're involved in from a Cancer Alliance perspective, the work we're leading on, the work we're collaborating with partners on. And I think it's really pertinent to reflect on the role that the Cancer Alliance has in light of the kind of the direction of travel from a model ICB perspective, and the ICB blueprint. I think whether it's our you know, collective expertise in understanding our population through the data and insights work that we do, development of the capacity and demand modelling in terms of that future-proofing from a demand and capacity perspective, having a deeper understanding of operational performance. We know that kind of like the back of our hand. The development of the longer-term population cancer strategy shows up. Developing the economic evaluation or exploring the potential, and particularly with kind of the specialised commissioning coming through to ICB, that real opportunity to commission cancer pathways for end-to-end pathway. I just think it's really kind of demonstrable, the work that we're doing from a Cancer Alliance perspective that fits into that model. So last but not least, in terms of from a summary and a recommendation perspective. So to summarise, performance challenges continue due to fragile workforce and capacity constraints. As I've said, the non-surgical oncology transformation will absolutely be critical in terms of, you know, to get right due to the growing demands that we've got coming through. Funding continues, so our service development funding continues to be deployed to support additional activity. And again, right-sizing that capacity will be key. We talked about demand and capacity modelling that we're doing, and those system service models will be key to ensuring resilience and timely access, and doing that work in partnership from an elective diagnostic and cancer perspective. Talked around shows up and how incredibly important that is, and the real opportunities regarding strategic commissioning to support the three shifts and improvement in outcomes. So Border has to note the current position around our performance, support the transformation priorities that I've discussed throughout the presentation, and that ring-fence service development funding allocation, the continuation of our public health-led partnership strategy, and just lastly, ensuring that the depth and breadth of the role and function of the Cancer Alliance that we've talked about is considered when we move towards the kind of evolving. And I apologise if I have spoke for a long time. So I'm going to.
Yeah, that was really interesting, Becky. I really enjoyed that. Thank you. Emma, Kirsten, do you want to add anything?
Other than to apologise
Right,
for being late, sorry about that. And I'm Kirsten Major, day job as exec of FD8, but I'm also the chair of the Cancer Alliance. But really happy not to add anything else and get involved in.
Really, really good presentation. Very cool. Emma, do you want to? I mean, I was interested, Kirsty, in something you said, and I genuinely hadn't appreciated this, which was, you said, when do I get the diagnosis? And are we waiting too long? Because I mean, I was trying to think it from the perspective of someone who's been through this with the family. When would I want it? I think I might want it earlier, genuinely. And then a few weeks later say, and this is what it means. So that's not about that's just about what I'd like. Now, I don't know whether I'm in a minority of that.
I mean, I suspect no, and I think it's something we need to consider as kind of diagnostic and treatment pathways change. It used to be really clear, cancer or not, but actually we now need to shape our pathways around you have cancer, we're testing for these 3 other things, treatment options will be A, B, C.
Depending on
you start getting your head around those, we'll come back to the further detail, but I think that's the place we need to go. And then I think in that context, I think the other thing we need to think about is face-to-face diagnosis. So best practice national pathways are everyone should only get a cancer diagnosis face-to-face. Well, actually, if it's we've consented you to, do you want to know as soon as we do? And if you do you want that in a phone call and we can then let you cogitate the options? I'd want that.
I think I'd want that. I think most people would.
Yeah, and we've done it on one tumour site by a kind of innovative team, and 98% of people consent to being told on the phone.
Tell me quick is what I think most people. Leslie, sorry, I didn't mind me asking that quick.
Thank you for the update. Really interesting and really useful update, which I think we've been asking for. Looking at the performance stuff, it's really clear, and we can see what that improvement in being like and what we're trying to do. I just wanted to talk about the human element though, because within all of those real people, and I just wonder if you could say a bit more about what's done to support people when they do know they've got cancer, but then they're waiting for starting treatment, and how we think that's impacting people, both in terms of obviously the cancer journey, but also psychologically and so, and what's done to support people in that way.
Key role for clinical nurse specialists, and that point where you have a diagnosis of cancer, you will have a CNS assigned to you to support you through that process. So proactive keeping in touch by the service in terms of what is the plan, when might you come forward for treatment, what needs to happen before. I mean, I think one of I'm not sure we're doing the prehab and we're not giving enough time sometimes for the prehab element because we're kind of racing to get treatment booked in, and we need to think about that differently. But CNS is the contact point for patients, and that's a two-way thing. That you get the mobile number for your CNS so that we can contact them with any questions. But we completely agree these pathways are not good enough. They're hard to be part of, whether that's diagnostic uncertainty or whether it's I've got a diagnosis of cancer, I know what treatment I'm going to have, but I haven't got a date for it yet. That's really tough. And I think one of the things that we don't describe anymore that Becky alluded to is the 31-day subsequent target is no longer a target. It's absolutely massive, and genuinely no underestimate that. So I get all the nice approved cancer drugs in my inbox every day. It's about 5 a day, and nearly all of them are subsequent treatment. So that is growing exponentially, and that's the same oncology capacity as the first treatment. And so they are being a really difficult balancing act about that subsequent treatment has a max of 8 weeks. That first treatment has a max of 12. How do we balance the needs of all of our patients? So it is really problematic, and it's not good enough, and nobody in it that form delivering it.
What feedback are we getting about people in that situation? How we take into account the that experience in terms of the improvements that we're trying to look at?
Well, I think our goals are for that. I feel there's quite a lot of things as well. Support, accessing appointments, the after appointments, some of that, what you call more social support as well. So that's fantastic. They offer fantastic services. And I think it comes back to, work, about people that are on workforce. I think it's about how we're actually going to, as it's not about the planning for this particular pathway, it's about that longer term pathway. So I think we're aware of all the risks, but it's about the patient harm, I guess, waiting for that diagnosis.
I guess it's about when you're taking a narrow view of patient harm, i.e. the cancer development, you have a worse outcome. But also, as we know, affects people in every aspect of their life and family. Does Western Park provide for everybody across that Yorkshire?
Got Kathy, then I've got Greg. Kathy.
Yeah, so thank you. It's really really helpful presentation and load in there. There's two parts that I just wanted to sort of ask about. So going back to the harm element, because I've been in lots of forums where we've had conversations around harm, how we're capturing harm and where we're reporting it, and then how that relates to outcomes for individuals. And I'm not sure I've sort of seen anything or really seen that crystallise. So it's sort of a question in that for me. And then the second part, I think is kind of probably based on what yourself in person have said, Pierce. So think back to our patient story that we had at the beginning of this meeting. Those processes and those sorts of pathways are really good if we white British digitally enabled from different communities. That kind of doesn't work for all. And I sort of say that as being a good class myself as a cancer nurse for 36 years, but also having people that have been through that pathway in my own family. So I think we just have to be really careful about trying to jump to the easy doctrine around some of these things.
Greg.
Cheers. Thank you, amazing run through the whole machinery. Thank you for it. I'll have many thoughts on the instance and screen. I'll pick up the privately. Wanted to pick up on the 9 through drug thing. That's where we spend the money. And there's a thing that taken not through the cost of 9 approval. That's where we spend the money. That didn't even get into the workforce. And then you get into the sort of the medicalisation of intensive medical care towards the end of life and all that kind of stuff. When, where, and how do we have that conversation with DHSC on thresholds and the like? I'd be happy to put again some homework into it because it matters. That's where our primary care budget is, basically. It's in that, extending people's lives by a minute. Sometimes probably a bit more than a minute, but you know what I mean.
I mean, I completely agree, Greg, and if our oncologists were in the room, they would agree.
Yeah, no, I agree. Yeah.
I think when those patients have a relationship with an oncologist, that generally goes really well, and they have very difficult conversations with patients. Where I think we need to be doing better societally is the level of expectation around second, third, fourth, fifth line treatments, which for many cancers we're now in that territory. I think the Royal College of Radiologists, which bizarrely that's where oncologists sit, well, clinical oncologists do. And so they are absolutely lobbying around the harm that perpetual approval of NHS drugs is doing. I've certainly made representations in NHS England about it, because what's also kind of goes below the surface is all of this stuff arrives in the inbox and it's all funded through the Cancer Drugs Fund, and nobody seems to worry about it in terms of their budget. But actually, you've got to put on 6 extra clinics, and that's a massive resource ask into the system. So I think a number of people are having those conversations, because I think sometimes people are on pathways that perhaps have fully understood the consequences.
I think it's much that there's a lot of the latter. No one talked them through this and the consequence of it, and I've seen that from my own family. And you think, I wish I'd have known. Yeah.
Just one question on the sort of demand side, really. I just wondered if anybody could be working anywhere around. Is our relatively late cancer identification a causal factor for our relatively poor 31 or 62 day performance? I'm just interested in the concept between sort of one met and the late met. So there is. I'm just, there's a scenario, isn't there, where you kind of go, the sooner we get to it, the easier it is. The better we put it there, the harder we make it. Yeah. So I was just wondering if anybody work in that space, because if we haven't, you kind of go, why the hell haven't? And then I was just, this whole concept about pathway optimization, giving them the dogs hope and the X-line therapy. I have a personal note about demanding capacity working that way because it's so really complicated. That's not that any distance work with Barkham, but I just kind of go, but I didn't really get that of compared with national comparators, the areas where we feel mildly quaint and about halfway, these are they, and this is specifically what we're doing about it. So there's a kind of aggregated question about augment versus late needs, and then there's a question about, I couldn't quite get a sense of a presentation on, there are these particular pathways, but now we're a bit more quaint and halfway optimization.
To take the part of the work that we're doing under the kind of the strategy piece is around that kind of economic case for change, and it's around that if we do nothing, this is where we're going to end up being. But then if we kind of change from a risk factor perspective here, or you know, if we're building these service improvements here and here, what does that? How does that impact from a kind of a patient journey? But what does that mean from a financial and activity perspective? And if I think about kind of lung cancer screening, so lung cancer screening, we've seen a significant shift, particularly in terms of late stage to early stage. And we're going to start doing some real kind of plotting of that through the life course model to really understand from a lung pathway perspective, what is the change in that kind of financial impact? And we're going to start working through that kind of pathway by pathway, and then understanding what does that mean for people kind of going back into work, etc. So we have started doing that.
I've got David, then I'm going to finish because I do have to finish this board meeting at some point.
So the reason why
I was on time till you walked in. Can I just?
The reason why this conversation, because active cancer treatment have revolutionised, and you know, we live longer. The downsides of that is that if you present early with cancer, then you'll have another cancer in your life and another cancer after that, so it balances itself off. The reality is, in clinical practice, stage 4 cancer is still walking my surgery every day, and you know, that's quite shocking. So it's unfortunately, you know, the more deprived communities who present there, and there isn't any treatment option. So I think it's complexly, to be honest. So there's that bit about whether we, you know, match the capacity and demand. There are so many, it's a moving piece. There are so many factors to consider. I just wonder how helpful that would be. But
I'm going to finish it. I'm going to take chairman's action. Firstly, can I thank you? That was great, really great work. But we did say as a board we needed it, and I found that particularly helpful. I guess the other thing that strikes me is almost what you were saying, David, how complex this has become. And there's a danger that we treat the target as if it was a waiting time target for a hip replacement, you know, an episodic one-off, do it, walk home. This is about clinically as far away from that, both before even diagnosis and afterwards, as you could possibly get. And I guess the bit that's kind of the macroeconomic stuff, Kirsten, is, and we're putting more and more money into the late stage treatment, and I'm not sure that the output is really worth it. Actually, there is other stuff that we should be putting our money on, even in cancer, let alone other stuff. But I'm going to take the liberty of finishing it there. Okay? Can I thank you? That was really good. Thanks for going along, Kirsten. Thank you for that. Everything else on the board is for reading. Okay? Did you get that?
Yes, sir.
Okay, thank you. God, I've never heard you call me that, but you can do that again. Okay, that's the end of the meeting. Thank you very much, everybody.